We are live.
Very good evening to one and all of you here. Today we are all poised to have the best of ARC webinars on our PG update series with a very exclusive expert panel and of course a great set of speakers we have got together. So talking of PG updates, Dr. Santosh Honavar is here with us, who has etched his name in our minds with a superb PG update program he puts forth for us in iFocus and of course the pre-conference day of AIOS, no one to beat him. We are also familiar to the fact that as an editor IGO for the second term, he has set an amazing trend in IGO with a soaring high impact factor, difficult to emulate by any, and we look forward to your pearls, Dr. Santosh, in this conference. We have with us the very eminent and daring surgeon with many and innovative complex procedures done with absolute ease. And guess who? It's Dr. Usha Kim, who's the Chief of Orbit Oculoplasty and Ocular Oncology Services in Arvind Eye Care Systems, and a major role player in the personal management therein, and of course has many awards and accolades with her. We are truly enlightened to have you with us, Dr. Usha. We have with us a very pleasant and endearing and a very prolific surgeon, Dr. Ashok Grover, a Padma Shri, an eminent past president of AIOS to remember and reckon, chairman of Ophthalmology Department of Sir Ganga Ram Hospital, chairman Vision Eye Care Centers, specialist in cataract, LASIK, oculoplasty, orbit, aesthetic oculoplasty, you name it, he's done it. And then also an individual with an amazing vision for ophthalmologists of today. I'm sure he's going to have scores of pearls for us today. We have with us Dr. Neelam Pushkar, who's a professor of ophthalmology at RP Center, New Delhi, with a major role play in eyelid reconstructive surgeries, involved majorly in research work in oculoplasty and oncology, a major presence in India and abroad in conferences of repute with more than 180 publications to her credit and more. I have with me as my co-moderator, Dr. Vidya, who is a senior consultant in orbit and oculoplasty at the Eye Foundation group of hospitals with a brilliance and dynamism of her own. So we shall now go on to the webinar. Our first speaker is going to be Dr. Hamid, who heads the pediatric strabismus, orbit, oculoplasty and neuro-ophthalmology at our Bangalore Eye Foundation, a product of RP Center, and truly with a strength to reckon and be proud of. He is going to be dwelling on orbital cellulitis, a very essential topic for the postgraduates, medical and surgical aspects with a lot of pearls thrown in. So on to you, Dr. Hamid.
Thank you, ma'am. Thank you for the introduction. I'll start sharing now.
You should be loud, Hamid.
Sure, ma'am. At the outset, thank you, AIOS and Chitra ma'am, for giving me the opportunity to present along with the experts. I'll be talking about orbital cellulitis today, its surgical and medical aspects. Orbital cellulitis is a serious infection and inflammation of the soft tissues of the orbit posterior to the orbital septum. If left untreated, it can lead to loss of vision and life-threatening consequences such as cavernous sinus thrombosis, meningitis, brain abscess, septicemia, and death. Orbital cellulitis involves the tissues behind the orbital septum, and preseptal cellulitis involves the tissues anterior to the orbital septum. I'll talk about preseptal cellulitis first. It is the infection of the eyelid and superficial periorbital soft tissues anterior to the orbital septum. It is more common than orbital cellulitis. The predisposing factors include trauma, sinusitis, foreign bodies, insect bites, skin infection, eyelid lesions, and iatrogenic causes such as eyelid and oral procedures. Clinically, it presents as an eyelid edema and erythema, and very important to note that it can mimic orbital cellulitis. In such cases, you need to avert the or pull the eyelids apart using a Desmas retractor if you're not able to manually open the eyelid and look for the status of the globe. Very important is there will be absence of proptosis, extraocular muscle restriction, and decreased vision. Treatment is simple. You just give broad spectrum oral antibiotics treated on an OPD basis. Close monitoring is very, very important as it can worsen and progress to orbital cellulitis. It has a good prognosis which recovers quickly. But in few cases, it requires admission and IV antibiotics such as patients less than 1 year, immunocompromised patients, and evidence of septicemia. So preseptal cellulitis can progress to orbital cellulitis. Very, very important to note. Very rarely, we also do surgery for preseptal cellulitis, usually in cases of presence of foreign body and eyelid abscess. Like this case, with the bilateral preseptal cellulitis with eyelid abscess that requires direct stabilization over the prominent portion of the abscess and helps in drainage of the abscess and promotes faster recovery with IV antibiotics later. Chandler classified orbital cellulitis into preseptal cellulitis, then orbital cellulitis. Stage 3, you have subperiosteal abscess in which there will be collection of pus between the bones and the periostem. Then the collection of the pus within the substance of the orbital tissue called as orbital abscess. Lastly is cavernous and as thrombosis. Coming to orbital cellulitis per se, it is the infectious inflammation that involves tissues posterior to the orbital septum, including the fat and muscle within the bony orbit. It is more common in children. You see bacterial orbital cellulitis more common than fungal. I'll be talking in detail about bacterial orbital cellulitis. Etiologically, it arises from the extension from periorbital structures like paranasal sinuses, infection of the lacrimal sacs, uh, infection of the teeth, skin infection of the face and the eyelid. It can arise from exogenous sources like trauma and surgery of the orbit. It can arise from within the orbit, like extension of infection from endophthalmitis and dacroadenitis. It can arise from a distant foci of infection through bacteremia. The most frequent cause of orbital cellulitis is secondary to extension of infection from the paranasal sinuses, especially the ethmoid sinus is involved in 70 to 90% of the cases, since it is comprised of a laminopaphyraceae, which is the thinnest part of the ethmoid bone, and it has many natural bony defects along with multiple natural foramina that allow easy passage of infection. Other peculiar feature of orbital veins is that they are valveless veins connecting to the pterygoid plexus and cavernous sinus. That also facilitates easy spread of infection to and fro. Coming to microbiology, historically, Haemophilus influenza type B was one of the most common organism. Since the introduction and administration of Haemophilus influenza vaccine in 1985, there has been marked decrease in the overall incidence of orbital cellulitis. But at the same time, it has caused expansion of infection caused by streptococcus and staphylococcal infection. And blood culture positivity is usually very low as there is no significant bacteremia. If at all it is positive, it will be more positive in children than in adults. Patients less than, it was found that the patients less than 9 years old usually have a single aerobe being the most common organism. In more than 9 years, you have polymicrobial infection. Post-traumatic causes of orbital cellulitis will have Staph aureus and Streptococcus being the more common organisms implicated. Anaerobic infection is more common in older children and adults and with history of trauma. Fungal infection is more common in immunocompromised patients. Clinically, orbital cellulitis presents with eyelid swelling, erythema, along with the presence of proptosis, conjunctival chemosis, limitation of extraocular movements, vision loss, relative afferent pupillary defect, and optic disc edema in rare cases. And in a few cases, it can also present with central retinal artery occlusion and vein occlusion. Valuation of a case of orbital cellulitis is very important. First and foremost is age. As we all know, it is more common in children. History of trauma helps us to know the presence of a foreign body. History of upper respiratory tract infection will point towards the presence of a sinusitis. History of fever, you ask history of diabetes mellitus. Since diabetes mellitus, uncontrolled diabetes mellitus can lead to fungal orbital cellulitis in adults. You ask history of any surgery in the past, history of systemic infection, and other ocular complaints should also be asked in detail. General and systemic examination should be thoroughly done to rule out any foci of infection, and ocular examination should also be checked, especially visual acuity, measure the amount of proptosis and amount of extraocular motility restriction, and look for exposure keratopathy, and also a dilated fundus examination is important. Investigation, you order for a complete blood count, which usually shows leukocytosis. ESR and CRP will be elevated, suggestive of infection or inflammation within the body. Bacterial and fungal culture should also be taken before starting the IV antibiotics. Overall, it has a low positivity rate, as I said. Liver function and renal function test should be ordered as a baseline since the antibiotics that we give can be nephrotoxic. Fasting blood sugar or random blood sugar should be ordered to check for the presence of uncontrolled diabetes. Cultures from the discharge or abscess should be taken as it has a more positivity rate. Imaging ultrasound is easily available. You use it for looking for the pus pockets, and also it is helpful in looking for the response to treatment. And it is also helpful in cases which mimic, especially retinoblastoma with orbital extension can present as aseptic cellulitis. You can now easily do ultrasound orbit to rule out calcification within the globe. CT scan is the imaging of choice as it is quick and provides better bony windows. whereas MRI helps in identification of any intracranial or cavernous sinus involvement. So CT scan, usually we order contrast enhanced CT scan of the orbit, paranasal sinuses, and the brain. It helps in evaluating the extent of the orbital infection, the source of infection, location of abscess, associated sinusitis, and cavernous sinus involvement. As you can see, there is involvement of the ethmoid sinus on both sides with the presence of a medial orbital, medial subparietal abscess in both the images. Here you have a superior subparietal abscess along with frontal sinusitis. It has a predilection for involvement of brain easily, so should be drained early. And this is an image of an intraorbital abscess. And MRI helps in identification of intracranial complications like subdural lymphoma and cavernous sinus thrombosis. Differential diagnosis, it is very important to differentiate intraocular retinoblastoma with orbital extension in children presenting with orbital stylitis, and simple ultrasonography may be useful in such cases to look for calcification. Then you have ruptured dermoid cyst can also present with orbital stylitis. Chocolate cyst or bleeding within the lymphangioma can also present with acute proptosis in kids, and leukemia with orbital metastasis. So chocolate cyst with orbital lymphangioma can present in this case of an acute orbital, the acute proptosis with congenital chemosis, which can mimic in the form of a orbital cellulitis, ruptured dermoid cyst, exposing the sequestered keratin to the immune system, causing aseptic inflammation of the orbit, presenting as orbital cellulitis. Medically, you should, as soon as you suspect orbital cellulitis, you need to start on IV antibiotics immediately. Empirical treatment should be started covering most common organisms like gram-positive organisms like streptococcus and staphylococcus. You can give vancomycin, which also covers methicillin-resistant Staph aureus. For covering the gram-negative organisms, you can start on third-generation cephalosporins like ceftriaxone and cefotaxime, which also have a higher CNS penetration. And for anaerobic infection, you need to start on metronidazole or clindamycin, especially in cases of trauma, dentine infection, gas-forming organisms, or foreign body. In cases of vancomycin allergy, you need to give linezolid. In suspected mucormycosis, IV amphotericin B should be started. Treatment should be modified based on the culture and sensitivity results. Appropriate treatment of the underlying sinusitis is very, very important. Like you can give saline nasal sprays, nasal decongestants, and nasal steroid sprays. This reduces the nasal congestion, facilitates the drainage of the sinuses, and reduces the anaerobic environment within the sinuses. There is a role of steroids, which is still controversial, but it does provide quicker resolution of fever, causes less pain, faster edema and proptosis resolution with faster return to return of normal ocular motility. It should be started 3 days after giving the IV antibiotics once you see there's an improvement of the orbital cellulitis, and it is contraindicated in suspected fungal cellulitis. Monitoring is very, very important. Careful monitoring of visual function and constitutional signs are very important to assess the treatment response, especially visual acuity, pupillary reactions, fundus examination, contralateral eye examination is very important. You need to have a consultation with a pediatrician to look for the systemic status of the child or the patient, otolaryngologist involvement in case of sinusitis, and neurosurgeon involvement in case of intracranial extension of the orbital cellulitis. Coming to surgical management, less than 9 years usually respond very well to medical management, even in the presence of a subparietal abscess. Younger children, anatomically, they have a wider ostia with a relative to the cavities that they drain, whereas as the child grows older, the ostium size remains same, but the cavity expands, creating an anaerobic environment leading to mixed infection in older children. And subparietal abscess is seen in 5 to 15% of the cases of orbital cellulitis, in which there is a collection of pus between the bones of the orbit and the periosteum. Is more common in medial orbit, as it is comprised of thin lamina papyracea with several perforations and loose periorbita. Frontal sinusitis can cause superior subparietal abscess, which can easily lead to frontal lobe abscess, and maxillary sinusitis causes inferior abscess. Indications of surgical drainage: immediate surgical drainage of abscess is required in cases of acute optic nerve or retinal compromise. In other cases, like there is in the presence of a large subparietal abscess, non-medial location of subparietal abscess, presence of frontal sinusitis, as it can lead to frontal lobe abscess, evidence of gas-producing organisms within the subparietal
You have
abscess,
to conclude, Dr. Hamid.
infection of dental origin, and patients who are older than 9 years also require. Uh, Indication of drainage of abscess under 9 years of age include vision loss, RAPD, absence of reduction of fever within 36 hours of appropriate treatment, clinical deterioration after 48 hours of appropriate medical treatment, and absence of clinical improvement after 72 hours of appropriate medical therapy requires drainage. Other indications include fungal infection, which requires extensive debridement, even exenteration if it is worsening should be done. Foreign body should be removed if there is presence of foreign body, and panophthalmitis resulting in orbital cellulitis if it is not responding to IV antibiotics, you need to do evisceration. Implant that is causing orbital cellulitis like buccal or glaucoma draining devices should also be done. Complications of orbital cellulitis include locally you have optic neuropathy, exposure keratopathy, disfiguring scar, and orbital osteomyelitis. Systemically, you have cavernous sinus thrombosis, meningitis, intracranial abscess, and rarely death also. So overall, when you see a case of orbital cellulitis, you order for a CT scan of the head, orbit, and PNS. Start the patient on IV antibiotics covering gram-positive and gram-negative organisms. Monitoring should be done for the next 48 hours. Response noted. Continue the IV antibiotics for at least 3 to 5 days. Then you can switch to oral antibiotics for 2 weeks and close follow-up on discharge required. If there is no response, you repeat the CT scan to look for any abscess. If there is any abscess, you need to drain immediately along with the otolaryngologist for the sinus drainage also. Response noted, continue with the IV antibiotics as advised before. And also you have to switch to different antibiotics based on the culture sensitivity at the same time. It produces very satisfying result if it is treated properly. Otherwise, it can lead to direct complication like even death. Take-home message is preceptal cellulitis can lead to orbital cellulitis. You need to have a proper and close follow-up of these patients. Patients less than 9 years of age usually respond well to IV antibiotics even in the presence of an abscess. Orbital cellulitis in adults with diabetes mellitus, you must have a high index of suspicion of fungal infection like mucormycosis, which can be fatal within hours. Thank you.
Thank you, Hamid, for a nice talk, but you really short your time. So if
Sorry,
everybody does that, we would have to compromise on discussion. So I really request all speakers, Mr. Sunil would inform you all 1 minute before your talk time ends. And please summarize at that point of time. And I have a question for you, Dr. Grover. Can you hear me?
Yes, I can.
How would you differ in your management of orbital cellulitis in a child as against an adult, and when would you get more aggressive than being conservative?
So one important aspect that I would like to emphasize for everybody is that in children, you need to be much more cautious. Even a preseptal cellulitis calls for a lot more attention because it can very rapidly go into an orbital cellulitis and go into cavernous sinus, go into further problems. So uh, even a preseptal cellulitis in a child needs to be taken care of. Second, ethmoid involvement is much more common in children. So the infection almost invariably comes from sinuses that needs to be treated concurrently. Third, you need to hospitalize them invariably and start IV antibiotics. And as very nicely mentioned, you need to take care of MRSA. And in a study from Madurai, almost 30% had MRSA. So you need to have vancomycin as one of the or one of those drugs which will take care of MRSA, and a gram-negative one. That is true for adults as well. In children, the difference is that up to 9 years of age, the study that was quoted, Harris, it has been shown that those children generally tend to respond to medical treatment, and uh, the requirement for abscess drainage, even if it is seen, is less common. Very infrequently would you need it. But monitoring has to be really good, and you should observe a response within 48 hours with your IV antibiotic. And you must very carefully watch the pupils and the visual signs. Otherwise, you risk a major problem of visual loss. And the role of steroids, generally it is accepted that you do, after you control the initial infection in the first 2-3 days, you can start steroids, and it significantly cuts down on hospitalization and on the eventual sequelae and the speed of recovery. So those are the salient things which you need to consider in a orbital cellulitis in a child particularly.
Dr. Vijay,
Sir, I have a question. With the rise in COVID, we get to see lots of mucormycosis, which is a deadly infection of the orbit. So, what is the investigation of choice, and whether swab will do, or we need to go for an incisional biopsy? How aggressive we have to be in detecting this? Like, it goes without saying that patient might lose his life if he miss this diagnosis. So, what would be the investigation of choice?
Being in a multi-specialty hospital, we have seen a huge spate of the mucormycosis. I think that's an entirely separate category. Of course, in diabetics, it's quite common. We were getting it very frequently, but post-COVID, we don't exactly know what the factor is, possibly use of immunosuppressive steroids, and the altered immune status is what is predisposing to orbital cellulitis by mucor. The most urgent thing is to work with an ENT surgeon who would examine the sinuses, since it is invariably a rhino-orbital mucormycosis. They are the ones who will take a biopsy from the nose, have a study, and if you can show mucor, you almost invariably can in these cases. And if you can show aseptate hyphae and you are able to confirm the diagnosis, then very aggressive treatment is called for, with explanation of the prognosis for vision and for life. And you need to gradually increase your dose of amphotericin B, making sure that you do not let the disease progress. At the same time, taking care of the systemic condition is vital. Diabetes or whatever immunocompromise that may have taken place is important. And aggressive treatment, including very often going on to exentrations. In post-COVID cases, somehow we've not required as many exentrations as we used to need in other cases, and we've in a number of cases used intraorbital amphotericin B, and we managed to avoid exentrations by, we've shown a gradual reduction of the orbital inflammation with that. So I think these things need to be kept in mind. Mucormycosis, high index of suspicion, and very quick treatment.
Thank you, Doctor. We shall now go on to our next speaker, Dr. Saptagirish, who will be dealing on ocular inflammatory disorders and bring everything to relevance in this topic. Dr. Saptagirish is the head of the Department of Orbit and Oculoplasty, Shankara Eye Hospital, Bangalore, and is a Dean of Shankara Academy of Vision. On to you, Doctor.
Good evening, one and all, and thank you, Dr. Chitra, for the introduction and also inviting me for the sessions. Good evening, one and all. I'll be talking on idiopathic orbital inflammatory diseases. I'm sorry, my video, there's little bandwidth issue, so my video may not be playing. So what is IOID? It's a benign, non-infective inflammatory condition of the orbit without any identifiable local or systemic cause. Now, it was first described in 1905 by Birch and Hirschfield, and subsequently it was called as inflammatory pseudotumor by Umiker et al. The reason why they called it as inflammatory pseudotumor is because it mimicked a malignancy of the orbit, and they ultimately found out that it was actually inflammation. It occurs in all ages, both men and women, with a mean age of about 45 years. But of late, the incidence, they say that it's slightly more female preponderance. It is one of the second most common cause of proptosis, which follows thyroid eye disease, and is the third most common orbital disorder after thyroid eye disease and lymphoproliferative conditions. And it also accounts for about 17% of cases in children. Now, it has been classified according to its location, onset, and histopathology. According to the location, it's known as diffuse, anterior, posterior, trochleitis, myositis, or dacryoadenitis. There are other rare types, which is known as periscleritis, perineuritis, and a focal mass. According to onset, it may be acute, subacute, or chronic. And according to histopathology, it may be classified as lymphocytic, granulomatous, or sclerosing. Now, the diagnosis of pseudotumor is basically a diagnosis of exclusion. And initially, before the histopathology was available and before all the drugs and imaging was available, apart from thyroid eye disease, almost every condition of the orbit was labeled as pseudotumor. So looking at this, there's been a major study which published in JAMA Ophthalmology in 2017. It's called the Consensus on Diagnostic Criteria of IOID. They used a modified Delphi approach. It was done by the Orbit group, which is basically based out of USA. They tried to answer one basic question, whether they can frame a diagnostic criteria for defining IOID, which is actually a disorder by exclusion. And they found, the findings were that they used the modified Delphi consensus with 35 international experts across the world, mostly from USA and Europe, and a few representations from Southeast Asia. And they came with a set of clinical and radiological criteria for the diagnosis of IOID, supported by tissue biopsy for the non-myocytic construct, and also by a prompt clinical response to a trial of systemic steroids for the myocytic construct, which basically means that now they've classified the orbital IOID as either being myocytic, that is involving the muscle, or the non-myocytic, which is also involving the other structures. Now, this means that basically the criteria specific for the diagnosis of IOID is defined, and it includes tissue biopsy for lesions, which is not confined to the extraocular muscles. At the time of publication in 2017, the study was done between June to July 2016 to 2016 Jan and published in 2017. It was not tested in clinical practice, but after the study, most of surgeons are actually trying to put this clinical practice. The most accurate assessment of IOID is, according to them, is by clinical indicators, which I'll just specify shortly. Imaging studies, which is either the CT or the MRI, selected normal lab findings, and an incisional biopsy for non-myocytic IOID and steroid responsiveness in myocytic IOID. So what are the clinical indicators? So the clinical presentation of IOID varies with the orbital tissue involved, with a degree of inflammation, associated fibrosis, and a mass effect. They may present with lid swelling, redness, ptosis, proptosis, and all the symptoms that we are aware of. But these symptoms which are mentioned here are in terms the source of the disease and largely are non-specific. So they came up with a specific set of symptoms and findings which is specific for IOID. The first one being orbital pain, which is the chief diagnostic criterion for IOID. 70% of patients with non-myocytic IOID actually have pain, which ranges from mild discomfort to very severe orbital and periorbital pain. And myocytic IOID is pain which is exacerbated in eye movements, usually on the gaze away from the action of the involved muscle. For example, if the lateral rectus is involved, the patient is trying to look in adduction, the patient is going to have pain. The onset is either acute or subacute, which is either days to weeks. Generally, the progression of IOI is a little slow. And there should be no history of orbital-related systemic diseases. So we should always exclude systemic diseases that may involve the orbit, like sarcoidosis and the IgG4-related diseases. Now, in relation to thyroid eye disease, it is not very strict to exclude thyroid eye disease because we know that patients can have, with thyroid eye disease, can also have concomitant orbital pseudotumor IOID. In relation to Crohn's and ulcerative colitis, it's not yet known whether it is a specific entity that involves the orbit or whether it's an epiphenomenon by itself. And pregnancy, orbital inflammation may arise during or after pregnancy, but the actual causal relationship is not yet established. Regarding the unilaterality, it is usually unilateral. And bilaterality is also common, it can happen, which may be simultaneous or sequential, which in the non-myocytic type is about 80 to 20%, and the myocytic type is about 14%. Usually, if the patient is presenting with bilateral disease, we should always look for a possibility of a systemic disease. And the age is generally between 10 to 75 years. There's been no racial differences, which they found out across the studies, and there is no racial differences too, but they found a slight female preponderance. Now, regarding the CT and MRI studies, the all IOID lesions, whether CT is done or whether there's an MRI done, they will enhance with contrast, and the amount of enhancement will depend upon the amount of edema which is there in the tissues. If the lacrimal gland is involved, there will be diffuse enlargement of both orbital as well as the palpebral lobes. And sometimes the swelling from the lacrimal gland can extend to the upper lid the surrounding fat, and also the lateral rectus or the superior rectus muscles. And when it is orbital fat IOID, it's generally of the sclerosing type, it is usually located in the superlateral orbit. And in myocytic IOID, there's usually horizontal recti involved, and both the tendon and muscle are thickened, but we should understand that it is not very specific that tendon sparing inflammation may not occur. It can happen in tendon sparing can happen in myocytic IOID, and the converse, we can have tendon involvement also in thyroid eye diseases. Now, there was a major study which tried to differentiate an orbital lymphoma and IOID, because orbital lymphoma also mimics IOID and the other way around. So there was a study in China, Shanghai, which they tried to see if the MRI and the histogram analysis of ADC maps, which is nothing but the apparent diffusion coefficient on diffusion weighted imaging, to see if they could actually differentiate between a lymphoma and IOID. And their recommendations were that the IOID shows higher ADC values as compared to lymphoma, and lymphomas showed higher skewness and kurtosis compared to IOID. So which means that on a standard MRI, we can also differentiate between a lymphoma and a IOID. Now, the lab investigations, they include a huge repertoire of investigations. We need a basic blood cell count. We need to do an IgG4, an ACE enzyme, and lysozyme. Now, when the lacrimal gland is solely involved, an anti-La estimation is important. Also, rheumatoid factor and the ACCPA and ACP and ANA. And when the extraocular muscles are solely involved, it's always better to do a thyroid profile because they could be concomitant. Now, histopathological evaluation of the biopsy generally shows a non-specific polymorphous infiltrate, and there may be presence of histiocytes and macrophages, and they may be actually focally organized as lymphoid follicles with a reactive germinal center. And immunohistochemistry is important because we've been thinking that IgG4 disease is very close to the way its orbital pseudotumor or IOID looks. But IgG4 positivity is not a prominent finding in IOID because it can happen in other orbital diseases too. But the ratio of IgG4 positive to total IgG plasma, if it is less than 40, it is significant. And presence of IgG4 positive plasma cells of 30 or less is compatible with the diagnosis of IOID. So as they discussed that the diagnostic confirmation of non-myocytic IOID is based on tissue biopsy, and of myocytic IOID is a trial of systemic steroids. Now this is different from our current practice wherein all types of IOID is actually treated with steroids. So tissue biopsies are critical for the diagnosis. And the role of screening is also important, but inflammatory markers cannot be very diagnostic because they may be generally raised in other conditions also along with the orbital inflammation. An autoimmune panel can be normal and they just relate to the burden of the disease.
Thanks, Doctor.
Can I just take a couple of minutes, please? Just a minute, please. I just wind up.
Yeah.
The main backbone of treatment has been systemic corticosteroids, which is given for both biopsy-proven non-myocytic IOID as well as myocytic IOID at the dose of 1 milligram per kilogram and slowly tapered over 6 to 8 weeks. There have been studies where they've tried intraorbital triamcinolone also with good response, and you can also use oral NSAIDs for mild cases. Now, in refractory cases, radiation has a good control rates of about 65 to 75% when the 10 to 30 guidance dose, and anterior lesions can also be treated with electron beam. Steroid sparing agents can also be tried in patients who are not responding very well to oral steroids. They're limited. I mean, we can try methotrexate, azathioprine, T-cell inhibitors such as cyclosporine A, alkylating agents such as cyclophosphamide, also B lymphocyte inhibitors such as rituximab, TNF-alpha inhibitors like infliximab, adalimumab. And there's been a study now where they've shown tocilizumab, which is an anti-IL-6 receptor antibody, to also have good response in patients who are refractory to steroid therapy. I'm sorry I've taken a little more time, and I just conclude my presentation here. Thank you very much, and I thank Dr. Chitra for giving me this opportunity, and also AIOC and ARC.
Thanks, Dr. Saptagesh. It was a wonderful, very crisp talk, and there was a lot of learning from your talk. I have a question for Dr. Usha. What would be your management algorithm, doctor? would you look at a trial of steroid for a couple of weeks and do biopsy for all cases, or would you differ?
This is Dr. Saptakiresh. Given the time, you've done a fantastic job. The way we would have to go about, at least what we should be practicing is, ideally when you suspect an inflammation, you probably, the best option would be steroids, a trial of steroids. But in case it's not responding, I think we should stop steroids for a period of 1 month and subsequently go in for a biopsy. The tendency that most people have is to do a biopsy without stopping steroids, which would give us a false diagnosis, or it'll be misleading. So it's best to do a biopsy, and the biopsy also should be representative tissue. Again, it could be misleading. So we need to do a deep biopsy in such scenario, and it's very, very important that we have a good histopathologist to look at because there are many, many variants. It could be vasculitis, it could be just sclerosis, it could be granulomatous, many different types, and all of which could lead us to an answer. And the empty box, which started off with pseudotumor, is now gradually getting filled up with definitive diagnosis. And most often it's all ending up towards giving steroids. If they don't respond to steroids, we always have other newer agents now. So initially start off with steroids, non-responders go in for a biopsy after stopping steroids, and then go in for other agents. And radiation also helps to a certain extent too in some of the patients.
Ma'am, when do you decide on definitive management, like definitive debulking surgery?
Now, if we have a large lesion and it's compromising any of the functions, probably I would go in for debulking alongside. So that gives us some adequate tissue for us to look at the histopathology as well. So only when it's compromising, otherwise just a sample biopsy is adequate for us. Just do an incisional biopsy and come out. But the sample should be adequate enough to give us a diagnosis. If it's compromising on the basic functions, then probably we'll have to resort to debulking.
So will it increase the inflammation, madam? Like, do we have to step up our steroid dose when we do a debulking surgery, or?
We would be probably doing it in any case in any orbital surgeries. We would be giving high dose steroids, right, to control all the inflammation. So in that context, you will have to step up the steroid dose that you're giving immediate post-operative period.
So we shall go on to our next speaker. Thanks a lot, Dr. Usha, for your pearls. Our next set on when, what, and how in socket surgeries starts with Dr. Manik Shah, who will detail on evisceration. And he is the Chief of Orbit Oculoplasty and Ocular Oncology Services at Advent Eye Care Systems at Tirunelveli. So let's hear from him.
Good evening to all. First, I thank Dr. Chitra Madam for giving me this opportunity. And also I thank my mentor, Dr. Usha Madam, for her constant guidance. The definition of evisceration is that is removal of intraocular contents while retaining an intact scleral shell with preserved extraocular muscles, optic nerve, and connective tissue attachments. Just a brief history about evisceration. In 1817, James Spear introduced evisceration. He did following an incidence of expulsive hemorrhage. In 1874, Noyes performed planned surgical evisceration following an intraocular infection. In 1884, Mulz described placing hollow glass sphere into the eviscerated cavity. This is an important revolution in the management. Coming to the indications for evisceration, endophthalmitis and panophthalmitis, these are the most common indication for evisceration. Because evisceration is indicated because that the infection, intraocular infection, will not spread to the subarachnoid space with the intact optic nerve sheath. So we are preferring evisceration. And other indication is anterior staphyloма. This is another most common indication. Here we can use implant also. So evisceration with implant will give good cosmetic results. Third indication is penetrating trauma. Here controversy is there whether we have to do enucleation or evisceration. But in view of risk of sympathetic ophthalmia, we can go for enucleation. But if there is not much uveal tissue prolapse, if we are able to remove entire uveal tissue, then we can prefer evisceration. Then fourth indication, blind eyes. There are two indications for removal. One is for pain control, another is for cosmesis. So always we have to consider evisceration as a first choice because it will give better cosmetic result. There are certain contraindications for evisceration such as intraocular tumor, phthisis bulbi, and there is an extensive globe trauma, nystagmus, which can lead to bizarre prosthesis movement, and autoimmune disorders with extensive involvement of the sclera, and whenever there is history of systemic malignancy. Then coming to the technique of evisceration, we can prefer local anesthesia or general anesthesia. General anesthesia is indicated in uncooperative patients, or if there is severe pain, then we can go for general anesthesia. Otherwise, we can do under local anesthesia. And also you have to obtain consent after proper counseling. That is very important. So we are going to do destructive procedure. So we have to get proper consent. Then second, medical officer opinion is needed before going for evisceration. And during surgery, we have to confirm the eye. That is very important. We should not do any wrong eye removal. That is more medically very much important. Then coming to the types of evisceration, there are two types: without retention of the cornea, with retention of the cornea. Most of our surgeons we are doing with without retention of cornea. This is the basic steps in evisceration technique. Peritomy, we have to do that is 360-degree conjunctival peritomy, and we try to preserve as much as conjunctiva possible so that wound closure will be easier. The next step is we have to remove the corneal button. That is, we have to make sharp incision at the limbus with the 11 blade. Then we can complete the corneal button with scissors. After that, we can use evisceration spoon to remove all intraocular contents, and we make sure that all uveal tissue should be removed to prevent the risk of sympathetic ophthalmia. Then finally, we can apply alcohol to denature the proteins. Then if you are planning for implant, then you have to do sclerotomy. There are different types of sclerotomy are there: radial sclerotomy, posterior sclerotomy, and 4-petal technique. So many techniques we can follow. It depends upon the what type of implant we are putting into the scleral cavity. Then implant placement. This also it will be dealt by subsequent speakers. How will you calculate the size of the implant and what type of implant we can put into the cavity. After putting implant, we should close the wound properly in layers. Then only we can prevent the extrusion of the implant. Then this is a video clip showing evisceration with implant.
1 minute left.
Just we are doing 360-degree conjunctival peritomy. After that, corneal button is removed. Corneal scleral button we can remove, and then we can remove all intraocular contents with evisceration spoon. This is an evisceration spoon. We can remove all the intraocular contents. This is all uveal tissue. We should make sure all uveal tissue should be removed. Then to put implant, we can put radial scleral cuts. This is a silicone implant. It is put inside the scleral cavity. Then overlying conjunctiva and tenons, we have to separate it from underlying sclera. And this wound closure is very important, as already mentioned. We can close the scleral with a 6-0 vicryl, and without undue tension, we have to close it. Otherwise, exposure will be more common. We can trim the ends also. So we do this. Then conjunctival and tenons can be sutured in different layers, or it can be closed as a single layer also. This also we are using 6-0 vicryl to close the wound. So good hemostasis with adequate closure will give good results. Finally, we can put conformer to maintain the fornixes. So this will complete the evisceration procedure. And this is another technique, but most of us are not doing, with retention of cornea. Whenever we plan for putting large implant, we can retain the cornea. Here you have to make sclerotomy 2 mm above the superior rectus incision site, and we should not pass into the choroid. Then we can pass the long cyclodialysis spatula to between the choroid and sclera to disinsert the uveal tissue at the scleral spur level. After that, we can extend the sclerotomy wound up to 160 degree. Then we can remove all intraocular contents with evisceration spoon and we have to achieve the hemostasis. Then we have to scrape the corneal endothelium and decimates to produce scarification. Then finally we can insert the implant inside also, and remaining same to our previous steps like sclera and conjunctiva and tenon should be closed. Then coming to the complications, these are early complications. Pain, it can be well controlled by analgesics. Infections, it can be controlled by sterile technique, peri and post-operative systemic antibiotic. Hemorrhage, which can be controlled by pressure pattern bandage for 24 hours. Then other complications also may happen like exposure or extrusion of the implant, wound dehiscence and granuloma formation. With our adequate surgical and good technique, we can prevent all these complications. Then late complication advantages of evisceration. It is an intraocular surgery, so it minimally affects the orbital contents. So orbital volume is minimally changed, and removal of infection without potential spread to the subarachnoid space. And also patient is a better psychological effect because the whole eye is not at all removed. And this procedure is quicker and better tolerated by elderly debilitated patients. And whenever we are putting implant with prosthesis, there is superior motility of the prosthesis will be there. And also we can use lighter prosthesis. There is no need for allograft for wrapping the implant material. And always there is a superior cosmetic result compared to enucleation. Then I likely to conclude that evisceration with so much modified techniques, we can put adequate size of implant into the scleral cavity. Thus we can achieve superior cosmetic and functional result. Thank you.
Thank you. Thank you very much, Doctor, for your detailed talk. One question to you, Dr. Neelam. It's a painless blind eye. What would you suggest for cosmesis for the patient without evisceration?
For the pain, you mean to say the painless blind eye?
Yes. Would you suggest cosmesis?
Yes, yes, sure. Actually, if it is painless and the size of the eyeball is okay, and we have to discuss with the patient that this eye might go into phthisis or a pre-phthisis, then the, putting appropriate implant size might become difficult. So we have to really counsel the patient about this, that in future probably the patient might require surgery. And at this stage, when the eyeball size is okay and it's PL negative, atrophic, it's better to, go ahead with the evisceration procedure with the implant, with the proper size implant. It will be, otherwise, theoretically, I can say that it would be better to go ahead with the evisceration surgery if patient wants. But the problem is that there is, a kind of psychological trauma, I personally feel, when we take out the eyeball of a patient, that psychological trauma, even if it's a non-seeing eye, is there. So this vary from case to case. It's very difficult to say like that I'll straight away go ahead with the artificial eye. So we have to really counsel, and we have to talk to them about the long-term consequences of keeping this blind eye. And as we all know, if the eye shrinks, the surgery is little more, complicated in the sense that we have to give relaxing cuts and we have to make a proper cavity to put the implant. So personally, when I see a patient like this who is PL negative, even if it is painless, I explain, and if patient wants, then I go ahead with evisceration. But one thing I want to highlight here is that ultrasound is very important before we do evisceration. We have to rule out any intraocular tumor. I think that is very important investigation, which should be emphasized to the residents, that they should do ultrasound and look for any intraocular pathology. And if there is any doubt, then please go ahead with enucleation rather than doing evisceration procedure. So that is my, personal opinion, that both ways we can go. If a patient has a normal eye, which is painless, we can just go ahead with artificial eye, but then we should also explain the patient about the long-term, things that can happen.
Thank you. Thank you. Dr. Vidya, do you have a question, or shall we move on?
Ma'am, in case of like endophthalmitis, when we are doing evisceration, will you be placing the primary implant, or you choose implant as a secondary procedure?
In endophthalmitis or even in panophthalmitis, if we are giving, IV antibiotics, once the infection is and the congestion is controlled to some extent, we go ahead with evisceration. And I always tell my resident that please put implant, because putting implant is very important. It maintains the the scleral cavity, and it's better to go for non-porous implants, the the spherical implants, because it said that porous implants can have infective organism in the pores, which can lead to problems later on. So I personally feel, and even for the cases we get, we prefer putting implant, even if a smaller size implant, suppose the sclera is necrosed, or suppose we feel that, the cavity is not very healthy, the tissues are not very healthy, go ahead with a smaller implant, but put some implant.
Okay. Thank you, ma'am.
Thank you. Next speaker is Dr. Dayakar Yadla, who would deal on the other relevant issue, enucleation. Dr. Dayakar is a medical consultant, orbit oculoplasty and ocular oncology services at the Arvind Eye Care Services based in Pondicherry. So let's hear from you.
Thank you, madam. Good evening. Good evening. Thank you, AIOS, and thank you, Chitra madam, for giving me this opportunity. Got finding trouble with my slides. Yeah. In the introduction, so this is one of the most difficult therapeutic decision to choose in enucleation. So before you choose the decision, like take into the account of a patient's psychological makeup. So your tone of voice, your body language, how you are going to break the bad news, it all makes difference. The visual potential of the eye, is there any vision the patient is going to get? That's what the most of the time they expect. They expect that once you remove the eye, we are going to place an artificial eye, and then they'll get back the vision. So we should tell clearly that they're not going to get back the vision. So we're going to improve the cosmesis. That's what we will explain. And then we have to discuss about the potential complications, intraoperative and postoperative. So always better to know about the history, because what our ancestors has done, we should not repeat the same mistakes again. So this procedure is one of the most oldest procedure in ophthalmology, dated back to 2600 BC. Then there are Chinese gods dedicated in ocularists. 1555 is the latest documentation, which shows there is a traction suture passing through the eyeball to pull the eyeball, so to do the enucleation. And then in 1840, in Dublin and Paris, they documented the procedure. After the invention of 1846 general anesthesia invention, the whole scenario of the enucleation is changed. The main aim of the procedure is to remove the diseased tissue and improve the patient comfort. So the most of the time patient comes and says doctor, please remove the eye. Please give me comfort. I'm not able to sleep. I feel like committing suicide. So you give the comfort to the patient. And then replace the orbital volume with the implants, which my subsequent speakers are going to talk. And the good functional and cosmetic result of the patient, motility and the cosmesis is able to provide. So that is the main aim of the procedure. If you go to the indications, most of the textbooks says the malignancies is the indication, but in our setup, trauma is the most common indication, especially the drink driving. They'll drunk and then they're driving in the two-wheeler, fall down and come like this. This is not uncommon. Then the intraocular malignancies, it's always difficult, especially in children. In textbook it says choroidal melanoma, but in our setup we see most common in retinoblastomas, especially children, anxious parents, precious child, difficult to convince them how to manage all that. Our experts are there, retinoblastoma, especially Dr. Santosh Anovar, Dr. Usha madam are going to talk. Then the most common in the exam, they'll ask you, what is the most common for enucleation is the cadaveric. That's what we should tell in the exams. And then the next is the painful blind eye. This is the painful blind eye. We said we'll give them steroids and then the atropine ointment and send them. This is one of our patients who came with the atropine allergy, full diffuse redness and diffuse pain. The patient is begging, please remove my eye. So that's what it comes like. And the indications for tumor, the most common intraocular malignancies. So intraocular malignancies, as I was talking, retinoblastomas. Next is the choroidal melanoma. So, but now the enucleation has become a rare with retinoblastoma because of the invention of intraarterial chemotherapies, intravenous chemotherapy and radiotherapy. And the eye salvage procedure and the vision salvage procedures are there. The next subsequent speakers will talk about it. Choroidal melanoma also, enucleation is rare if you identify early. There are a lot of debate, after enucleation, chance of metastasis is more because of the seedling, tumor seedling. Then the enucleation, when you're doing, go for the no touch technique. And there are a popular video by Santosh Hanover, the bioconjunctival technique of implant placement that shows exactly the no-touch technique. And any other neoplasms are the indications for enucleation. The trauma and the primary, in the trauma, we can divide into primary enucleation and secondary enucleation. The primary enucleation, the affected eye has a no light perception. Please check the light perception with the indirect ophthalmoscopy. Don't check the other normal torch lights. And the pupillary response should be absent. An extensive corneoscleral laceration, which has a posterior margin extending beyond the ora serrata, where we are not able to visualize the posterior extent. And you have a setup where you have a frozen section which can document the collapsed uvea retina in the wound. That's the perfect evidence for medical legal cases. The fellow eye should be normal. The patient should be alert and cooperative. That is the most difficult part, because the patient most of the time they'll be drunk or a drug abuse. The patient or a guardian understand that removal of traumatized eye precludes the return of vision. That is the most important. Next is the indications in the trauma secondary enucleation. So otherwise called sympathetic ophthalmia. This is a relative contraindication. To recap, the injured eye is called the exciting eye. The normal eye is called the sympathizing eye. The most of the time sympathizing eye will have a less vision. The exciting eye will have a better vision. It's very difficult to go for an enucleation in an exciting eye. The incidence of sympathetic ophthalmia is like 1 in 1,000 to 2 in 100 in traumatized eyes. In the Massachusetts Eye and Ear Infirmary has confirmed that 65% of cases occurred in 2 weeks to 3 months time. So enucleation, if at all you are planning to do, go for a less than 2 weeks time to prevent the sympathetic ophthalmitis. This is one of our patients who had a fall from the two-wheeler drunk driving, then came like we have somewhere they've done a evisceration, but the copious discharge of pus. So we're not sure what is happening. Always go for imaging, rule out foreign body. This is the foreign body, wooden foreign bodies, especially wooden foreign bodies is difficult to identify in immediate post-op. So it will take 2 to 3 weeks to get an air shadow, then look for air shadow and try to remove that. Otherwise it will not going to help. Other indications are painful blind eye, and then the cosmesis, the neovascular glaucoma. After the invention of the intravitreal Avastin injections, neovascular glaucoma managing is better, enucleation is come down. Then uveitis or endophthalmitis, as my previous speaker was talking. And then there's a cosmesis, especially the young girls, like their psychological appearance, behavior, everything changes. You can see in this picture. So then there is a very rare, I read only in textbook, like autoenucleations called odipism, where the patient himself removes psychological disturbance, removes their eye and resectant comes. The contraindications, and then any malignancy which spread to the orbit. So it is always better to not to do the enucleation and rule out a systemic spread. Then the sympathetic ophthalmitis, already established sympathetic ophthalmitis is a relative contraindication. And the poor general condition, patient is bedridden, patient is going to die, like there is no point to doing more harm, more pain to the patient. And similarly, psychological disturbance where they cannot give a consent. Written consent is the most important part. So if they're not able to give a consent, then better not to go ahead with it. The enucleation surgery, always go for a pre-operative evaluation. Make sure that you thorough evaluation. Get an informed written consent clearly.
Doctor, 1 minute.
Okay, I'll click. Then always general anesthesia. Do one general anesthesia with retrobulbar block, because it causes the oculocardiac reflex. To prevent the oculocardiac reflex, do a retrobulbar block. And the medical problems, especially the anticoagulants and the bleeding, should be evaluated before. This is my video. For a lack of time, I'm skipping the video. Then the complications is divided into intraoperative, postoperative, and early and late complications. Intraoperative complications, removal of the wrong eye. This is the worst nightmare any person, any professional can have. Nobody can save you if you do the wrong eye enucleation. Then loss of rectus muscle, you can retrieve it. Hemorrhage, usually you do the thorough cautery, especially anticoagulants. Then do a pressure bandage for 24 to 48 hours, but we can go up to 5 to 7 days if the bleeding is more. Late postoperative, like a lax socket, and then the post-enucleation socket syndrome. In the dry socket, when there is a damage to the lacrimal apparatus, lacrimal gland. Discharge when there is a granulomous tissue, difficulty in retaining the prosthesis, like enophthalmos due to fat atrophy. Pain is the worst in the pain. This post-operative pain, they say like I might commit suicide. Normal analytics will not work. Go for a tricyclic antidepressants. So that is the painkiller. So you should use it. Cosmesis is the one we always address before. Always invest on your ocularist. They will make your life easier.
Doctor, time's up.
It's done. Finished. Thank you. This is one of our happiest patients. Thank you.
Thank you very much, Doctor. Dr. Santosh, I have a question here. How do you ensure that the eye movements are retained as we are going to be disinserting the extraocular muscles in this case?
Well, there are many ways of doing it. One of which is you suture the muscles back to just close to the fornices. That's called myoconjunctival technique. The second one is to use integrated implants. Integrated implants are biointegrated implants, which are hydroxyapatite or porous polyethylene, which get integrated with the orbital soft tissues, to which the muscles, of course, will be attached. And that improves mobility depending on whether you kind of drill the implant or not. So the procedure is that you put in an implant first, and after it vascularizes, drill and peg the implant. And to the peg, the prosthesis gets indirectly attached. So that will ensure the best of moments.
Supposing the implant was not placed in the primary setting, so how do we go about it, sir?
You can do a secondary implant. If the surface is adequate, then secondary implant is the treatment of choice. Suppose surface is also compromised, suppose you have both volume loss as well as surface loss, then a dermis fat graft would be more appropriate.
Thank you, sir.
So our next speaker is Dr. Neelam Pushkar, and she's going to be talking on exenteration and when and how. Dr. Neelam, I would want you to hold on to the time because all speakers have to do justice. Thank you.
Yeah, sure, ma'am. Good evening, everyone, and thank you, Dr. Chitra, ma'am, for giving me this opportunity. And so I'll be talking about exenteration. Exenteration, we all know, involves removal of entire content of the orbit, including periorbita, appendages, eyelids, and surrounding skin also sometimes. Though it's a life-saving procedure, but it's quite disfiguring surgery, as you can see here. It is performed by a trained oculoplastic surgeon. So since we want to avoid exenteration, and with the better understanding of chemotherapeutic drugs and use of new adjuvant chemotherapy for chemo-reducing the tumor, which allows the conservative surgery. So in orbital diseases also, there are some case scenarios where we try to chemo-reduce, like in eyelid malignancy, in squamous cell carcinoma, sebaceous cell carcinoma with limited anterior orbital involvement. We have seen very good response and we've been able to salvage the globe. Then lacrimal gland tumor with limited soft tissue infiltration. Then of course, retinoblastoma with orbital invasion. We are not doing exenteration at all, Then in patients like orbital rhabdomyosarcoma and lymphomas, our role is just to do biopsy, and rest of the things is taken care of by the oncologist people. Exenteration. So coming to the indications of upfront exenteration, eyelid malignancies with extensive orbital involvement, melanomas, we know they are not chemosensitive. So if there is orbital invasion, it's better to do upfront exenteration. Then lacrimal gland tumor or any other malignancy where there is diffuse tissue infiltration or apical involvement, malignancy that progresses, despite your chemotherapy, or where chemotherapy cannot be administered, like in old patients. Then necrotizing infections, especially mucormycosis, and rarely we do exenteration nowadays in invasive aspergillosis, because we know that the results with voriconazole is very good. These are some patients, as you can see, extensive malignancy with maggots, neglected patient underwent exenteration. This is another patient with melanoma with orbital invasion. This is a young patient during COVID time. He came with, the sinus and the cheek area, mucormycosis. So this particular patient underwent exenteration, which was extended exenteration, because the orbital contents along with the maxilla, whole maxilla was removed and sinus debridement was done. And this patient, you can see there is melanoma with orbital extension. So here you can see this is the exenterated socket after 3 months. It's epithelialized. So this is just to briefly show the data of these patients presenting over 30 years in RP Center. This data has been collated by Dr. Sahil Agarwal, senior resident, who is working on this paper. And this is just to show that, if you see, there are two color bars. The blue one is before 2000. If you see here before 2000, the indication was mainly intraocular malignancy, which was basically, orbital retinoblastoma. These patients no more we do exenteration. So now you can see that in last 2 decades, the commonest indication of exenteration is eyelid malignancy. And this is just to show the trend that there is a declining trend of exenteration nowadays. Coming to types, So partial orbital exentration, as the name suggests, is basically you can call this extended enucleation, generally done in benign lesions which are infiltrative, recurrent, large in size. Total orbital exentration is basically when we remove whole contents of the orbit with or without preservation of eyelid skin. Then extended orbital exentration is when we remove a part of orbital bone, and radical is when we, along with the orbital exentration, we are taking out, say, whole of maxillary sinus or large bulk of cranial tissue. So partial and total independently can be done by oculoplasty surgeons, but the extended and radical requires a team. This is just to show so that residents, they understand this is orbital exentration. When you take out the wall of the orbit, this worm's extended, and radical is when the whole of, say, maxilla or the cranial or, large structure surrounding the orbit is also removed. So as we know, this is a destructive surgery. Definitive diagnosis is a must in these patients. Imaging, preferably CT scan, because we want to see the bone status of the bone, if there is any erosion or defect, and we have to be prepared accordingly. We discuss with the oncologist if something can be done, to salvage the globe and important structures. Then we have to counsel the patient and also counsel the caregiver. This part is very important in exentration because the amount of disfigurement is something which is not acceptable. So that has to be done. Then we explain about the prosthesis beforehand so that it basically then helps in reducing the level of anxiety and depression in these patients. Special consent for exentration has to be taken because this is a destructive surgery. The need for further investigation, you have to do all the pre-anesthesia checkup. ICU backup is also required, especially in extended or radical exentration. Then accordingly, you send the consults to the other specialty surgeons also. This is just to explain some steps, though I'll be showing video also. This is a skin sparing exentration. You can see that along the just 3-4 mm from the lid margin, a cut circumferential incision is given in the skin. Sparing the orbicularis, we reach the orbital rim, and then finally, we take out the whole content and we close the cavity like this. So this is a closed cavity over here. The advantage is that this skin basically adheres with the bone and the area heals in 3 weeks time, and then patient can be given prosthesis early. Disadvantage is that the eyebrow sometimes drawn in the orbital cavity, which makes the fitting of the orbital prosthesis difficult. This is a exentration video I'll be showing, so it's better that we understand here that we give the incision, along the orbital rim all around. We reach the bone straight away, and we, incise the periosteum with the elevator. We go in that subperiosteal space of the orbit all around. We put a clamp at the apex, and then we use enucleation scissors and we cut and remove the whole thing. So when we talk about orbital socket reconstruction, we basically refers to how to line this bare bone. Or suppose if we have done extended or say radical exentration, then how to restore or how to fill that defect. So for total exentration, which can be handled by the oculoplasty surgeon, we have options of either we can spare the eyelid skin where it is possible, and this heals in 3 to 4 weeks, and or we can go ahead with split thickness skin graft, but then this will increase the anesthesia time, and most of these patients are morbid. The healing in this is around 2 months, and if we leave it bare, this is the easiest way of doing it. The socket granulates and it's lined with epithelium in 3 to 6 months. Extended and radical exentration, we have to take help of facial-maxillary surgeon, plastic surgeon, so that they raise some flap and fill in the defect. Advantage of reconstruction, as we can see, it helps in promoting the healing of the socket. It helps in early rehabilitation with prosthesis, timely radiotherapy, which can be given in these patients after 4 to 6 weeks of surgery. Disadvantages are donor site morbidity and increased surgical time. Complications of exentration are delayed healing, especially if we are leaving the bone bare. Or they can be a bony fistula if you have traumatized the, the bone of the orbit, especially the medial orbit. They can be bone necrosis in patient with radiotherapy, infection, numbness. These are expected, especially the numbness part. Secondary procedure sometimes is required if there is, complication and there is inability to fit the artificial, the prosthetic eye. This is a patient video I'll be showing. This is a patient with recurrent adenoid cystic carcinoma, and this was a exentration where the skin was not preserved. So you can see that the cut is all around, along the orbital rim. We are using cutting cautery. It's always better to use cutting cautery to minimize the bleeding. And straight we reach to the, the bone. And once we gently start from the, the infralateral part of it, because that is the area where the bleeding is less. And in the end, we come to the medial side of it. So after giving incision in the periosteum, we lift the periorbita, we enter the periosteal space. And whatever strong structures are there, like lateral canthus, you can see, we need to cut them. So all the strong attachment with the orbit, we need to cut, like lateral canthus, the medial canthus, and the lacrimal gland area, the inferior oblique area. So we have to basically circumferentially, we have to go all along with the minimal bleeding, as you can see here. And we have to, this is the periosteum elevator being used to separate the periosteum from the underlying bone. And suction should also be ready. And here you can see the oblique muscle is being cut. And in the end, we have come to the medial side. Now the after clamp, we have cut, and the whole thing we remove out. And it's better to, take out some tissue from the apex and try to have a deep cavity, because in deep cavity, you can fit the prosthesis better. We pack it, and the bare side, if bone is bare, visible, you can put 1-2 sutures over there. So this is how on the third day, generally we remove the pack, and this you can see the bare bone and with some granulation tissue which is appearing. This is a healthy socket. These patients, they need dressing, frequent change of dressing with antibiotic for almost 2 weeks. After that, we can leave the socket open. We can advise them to use some spectacles with occluders or with the patch till the time orbital prosthesis is given. Coming to prosthetic rehabilitation, very important part of this treatment, it improves the quality of life and reduces the psychological distress. And this is done free of cost in the Department of Maxillofacial Prosthodontist here in AIMS. And a few customized prostheses I'll be showing. This is spectacle mounted prosthesis, as you can see here. This patient underwent bilateral excenteration, and if you see, the spectacle, there is medially, there is attached prosthesis, and this is how it appears after wearing it. It's a very lightweight, user-friendly prosthesis and quite economical. This is another customized, prosthesis you can see here in a patient with the orbital and the facial defect. So this prosthesis, basically adhesive has been used to retain the prosthesis. So depending on the defect, if it is orbital defect, we can just make the orbital prosthesis and use the adhesive. So you can see the cosmetically, though the eukosmesis is suboptimal in these patients, but at least there is something to look forward to. So this is another patient where there is orbital cavity, and along with that maxilla was also removed. And you can see that there are 2 prostheses. One is for the oral, which is taken inside from the mouth. This is the orbital part of the prosthesis, and there is a magnet which is there. So magnet is there both in orbital and the oral part of the prosthesis, and it helps in keeping it in place. So this is how the patient looks after wearing the prosthesis. So take-home message is that orbital exenteration is a mutilating surgical procedure. Definitive tissue diagnosis is mandatory in these patients. Preoperative special consent and counseling is very important, both of the patient and caregiver. And patient has to be explained that despite such a destructive surgery, the disease might recur. Then there is a need to, follow up and have further treatment. And it is definitely a teamwork. I would like to acknowledge contribution of all these doctors who helped me in, preparing this talk. Thank you.
Thank you, Dr. Neelam. I have a question for you, Dr. Santosh. When would you decide on a lid sparing procedure or a lid involving one?
Well, it depends on, I think, the indication. If the eyelid is already completely involved, then there is no way you can spare the lid. But if it's primarily an orbital tumor for which you're doing orbital exenteration, then I would always like to spare the lid so that I can get a primary closure, and patient rehabilitation and further fitting of the prosthesis becomes much accelerated, and patient remains comfortable. But if the lid is completely involved, there is no skin to spare, then you can do a flap, temporal flap. That would be the safest way to close the defect.
Dr. Vidya, you have a question?
If we leave the socket to granulate by itself, is the incidence of sinoantral fistula high? Or,
yes, it is high, and also it takes about 6 months and a lot of cleaning, a lot of patient visits, or the patient himself has to douche and clean properly. Otherwise, it can cause breakdown of the socket lining, that is granulation, bleeding, keratinization, all that. So I would definitely want to close as far as possible. If that is possible, if it's impossible, then only I would leave the socket to granulate.
And also the prosthetic rehabilitation will also be a little different, no, sir, in these cases?
Yes.
You might have to give an obturator or something?
Well, you don't have to give an obturator unless there is a fistula with the sinus,
okay,
or of the palate or the nose. Otherwise, you can simply fit a prosthesis with the rim that is available. You can rest the prosthesis on the rim. You can use a spectacle mounted prosthesis, but a stick-on prosthesis, like you would give a silicone glue stick-on prosthesis that you can give with a lid sparing exentration, is not possible if you have sacrificed the skin. One more way of doing it is osseointegrated prosthesis, where you put pegs within the bone and integrate it with the bone that is available at the rim. And then that can be magnetic device which can get coupled with a prosthesis that is fitted on top.
Thank you, Dr. Santosh. So we shall go on to our next speaker, Dr. Ishan Acharya, who's going to be detailing on orbital implants overview. And Dr. Ishan is a consultant of Orbit Eye Hospital, Vadodara, and has an exclusive oculoplasty services practice, a very experienced and dynamic surgeon. On to you, doctor.
Thank you. Thank you, AIOS and Dr. Chitra Madam, for inviting me for the PG update. Let us start with some terms which are used in an ophthalmic socket reconstruction. So, better term would be an ophthalmic implant rather than orbital implant, conformer, scleral shell, prosthesis, and peg. So, an ophthalmic implant, they are used to replace the volume and to enhance the motility of the eviscerated or enucleated socket, and they are actually placed intraoperatively. And they come in different sizes and shapes, like you are seeing here, and different materials also. Conformer is a transparent thin shell with holes, which is placed post-operatively to retain or to form the fornices of the socket. Scleral shell is a very thin, very thin shell with cornea on it. It can be transparent or it can be opaque also, and is put usually on the atrophic bulbi or phthisis bulbi, where volume is little less. And prosthesis is actually a prosthesis which can be a stock eye or which can be a custom made eye. The advantages of custom eye are follows the contour of the socket, better prosthetic motility, excellent cosmesis, and much longer shelf life, and they are made by an oculist. So here this patient has a conformer in place, this patient has transparent shell, and this patient has opaque shell in place. So why an implant is required to after doing any enucleation or evisceration? Basically, the main purposes are volume replacement and motility enhancement. And in congenital anophthalmos, the orbital implant will stimulate the growth in the children. So if no implant is put, you can see here, you can see the significant anophthalmos. You can see the posterior tilt of the prosthesis, deep superior sulcus deformity, and backward tilt of the prosthesis. And sometimes it leads to the lid retraction also in some patients, basically because of the posterior rotation of the superior rectus and levator complex, and forward rotation of the fat, inferior orbital fat, and inferior rectus. So if smaller implant is placed, you can see again here the anophthalmos deep superior sulcus and sagging lower lid because of heavier prosthesis. Now, compared to that, this patient, you can see this is the prosthetic eye. I can enhance that. And you can see the best cosmesis which can be achieved is achieved in this patient with lid screen and lid crease and all lower lid, all contour are all okay. Now, if larger implant is placed, it can cause wound dehiscence, implant exposure, flattening of the fornices, and thereby the movement of the prosthesis will be compromised because the less space is available. So there will be decrease in the motility, and you may not be able to appreciate the anterior chamber depth in thin prosthesis because larger implant will occupy more space and the prosthesis will be thinner than what is required. This is the video showing the implant motility. These implant motility, this is a this integrated implant, sphere implant, and you can see now the very good transfer of the motility to the prosthesis. Now, compared to that video, you can see here in this video the prosthesis motility is little lesser. So there can be a larger implant in place, or there can be shortening of the fornices during the surgery also by pulling the tissues. So motility is very important post-operatively, and we have to be very very accurate with the technique also and the placement of the implant. In congenital case of congenital anophthalmos, we can use this self-expanding hydrogel orbital implant, and also there is injectable pellet expander also, but they are of, and usually they are not used because better this equipment, these are available like better ways are available by enlarging the conformer gradually. You can see the base result. So base time is to put an implant is a primary orbital implant, while we do the enucleation or evisceration only, as very well informed by Dr. Neelam madam. But we may have to go for secondary implant, that is already the eye has been removed, and we go for secondary implant. So now what size implant should we put? See, when you remove the eye, it also comes along with, especially in enucleation, along with some soft tissue, and there is soft tissue contracture or fat atrophy, which is again debatable, but averagely there is 7 to 9 ml volume loss. So we have to replace that 7 to 9 ml to give best prosthesis, and that should be given by the implant. Wrap may or may not be used, and prosthesis, so almost 7 ml to be used. So ideally 80% of the volume should be replaced by the implant itself and 20% by the prosthesis. So prosthesis is usually around 2 to 2.5 ml, and that will, if it is more than that, the volume of prosthesis, if it is more than that, it will be significantly heavy, and it will be it will put its weight on the lower lid and thereby causing sagging of the lower lid. So these are the size of the implant and the volume available. So we can go through those charts when we measure. There are implant sizes also intraoperatively which can be used, and we can put it in intraoperatively, and we can see that whether the closure is tight or adequate. So for enucleation, there are nomograms available according to axial length of the normal eye to decide the volume of the or size of the implant, or either we can place the 10 cc, we can take the saline and put enucleated eye 20 cc, and we can put enucleated eye in that, and we can measure the displacement in the water, and thereby deciding the size of the water. The best thing is to use your experience. So globe volume minus prosthesis volume will be implant volume. So almost 4.7 cc should be replaced. That will come to 21 mm diameter of an orbital implant. So that is not an easy to put during evisceration especially, but in enucleation it may be possible to do that. So for evisceration, there are no clear-cut guidelines available. Radial sclerotomy should be done to accommodate larger implant, and approximately 18 to 20 mm size.
Doctor, 1 minute left.
In classification of the implant, non-integrated, integrated, and semi was integrated. So there are PMMA implant and silicone implant. PMMA is now commonly used. These are quasi-integrated implant which have very irregular anterior surface, but they are abandoned now. Nobody uses them. This is exposed implant. There are exposed integrated implant, which some part of the implant is inside the conjunctiva in the socket, and some part is exposed. Some part is exposed. Porous implant are natural hydroxyapatite implant, porous polyethylene, synthetic hydroxyapatite implant, bioceramic, and they were introduced to avoid extrusion, exposure, and to provide better motility, reduce the risk of implant infection, but none are proven definitely. You require pegging to provide better motility, implanting movements. And one is exposed buried integrated implant like dermis fat graft, which provides volume and surface both. So this is actually conjunctivalization has started here in the second photograph. So porous versus non-porous debate goes on. Two major reviews conclude that there is little evidence that the implant migration is laced with porous orbital implants. There is little evidence to support the suggestion that porous implant have a reduced infection rate. Without the peg in place, there is no proven motility advantage of porous over non-porous implants. The most common sequel is asymmetry. You can see here what is almost very difficult to achieve.
Mute all of us, Mr. Sunil.
Yeah. You can, this patient has less volume. Post subperiosteal implant has been put. Again, congenital enophthalmos. Symmetry is not there, but because of congenital microphthalmos. So asymmetry can be because of smaller, larger migration, small socket, or wrong prosthesis fitting. Migration is also common in this non-integrated implant. Exposure is like this, and patient may come in hand with the implant. Integrated implants are exposure is very high, expensive, and there is cyst formation also. So concluding, new implants used to be evaluated over a long period of time. For Indian patients in general, non-porous implants are extremely cost effective. Affording patients can be given the option of integrated implant with minor complications. Thank you.
Thank you very much, Doctor. Vidya, can you take one question before we go on to our next speaker? Dr. Vidya?
In case of children, like when they require enucleation or evisceration, we end up putting a smaller implant. But as they grow old, the implant becomes small, and there might be poor cosmesis. How do you deal with this problem? How do we achieve?
Usually, maximum 90 for more than 95% of the facial growth occurs by the age of 5 years, 5 to 6 years, and orbital growth also. So before that, if I want to put an implant, I will definitely go for largest implant if available, if possible, to put in that socket. Otherwise, I can go for the dermis fat graft also.
So over the implant, you will also use dermis fat graft?
No. Even only dermis fat graft can do.
Okay.
Thank you, Doctor. Our next speaker is Dr. Seema Das, who is going to be dealing on management of anophthalmic contracted socket and is a senior consultant from Shroff Charity Eye Hospital. On to you, Doctor.
Thank you, Dr. Chitra. Thank you, AIOS, and thank you, Dr. Santosh, for this opportunity to speak in this PG teaching forum. So I'll be speaking about the management of anophthalmic contracted socket. And we all know contracted socket could be either acquired or could be congenital. For the purpose of this talk, I'll just focus on the acquired type. Congenital itself is a separate topic. So we know ideal socket, as the previous speakers have enumerated, should have a very well-centered implant, should have good volume replacement, should have good surface, the eyelids and the movement should be good. Anything if goes wrong in any of these parameters can make the socket land up in what we call as contracted socket, where a good prosthesis cannot be fitted. Like in any other pathology, prevention is the best thing to do. So best is to not to create a contracted socket and take adequate precautions during surgery, especially while doing an evisceration, so that we don't land up losing the conjunctiva. So what I want to just emphasize in this video is that while excising or doing the peritomy in conjunctiva, especially for infected evisceration, please make sure that we don't excise any conjunctiva and our peritomy is very flush with the limbus. This is sometimes a mistake where the new surgeons do, especially if the conjunctiva is very boggy and chemotic, and there is a tendency to excise some of conjunctiva, and we'll end up with an infected socket. So this is the age-old classification for the contracted socket that we all have been following, and this mainly focuses on the surface part of the socket, and according to which the socket is graded. And though it is important to look at the surface of the socket, it's also important to look at other parameters like what is the position of the eyelid, is there any entropion, how is the movement, is there any associated bony contraction, how is the volume, which most of which are not covered only by this classification. Surface is very important. These are the most common causes of contracted socket. We need to differentiate between a shelving of the fornix, which are sometimes seen in patients with long-standing post-enucleation socket syndrome. I'll come to the details of it. We also need to see how badly contracted the surface is. Is it just a mild shortening of one of the fornices, or is it like all the fornix are very cicatrized and there is a lot of scarring? Also important to look at how is the surface of the conjunctiva. Is it dry and with a lot of keratinization, or is it moist and healthy looking conjunctiva? Volume replacement is the first part. Whenever we do a socket reconstruction, we start from the posterior part. We replace the volume in the posterior part of the orbit, and then we come anteriorly to the socket and finally to the eyelids. So we know that volume loss has its own features like a deep superior sulcus, a look of inophthalmos, and when we replace the volume by putting an implant, the superior sulcus gets filled up like this and the inophthalmos gets corrected. However, in settings of post-trauma, especially in patients like this, where even after doing and putting an adequate sized implant and replacing the volume, if there is still a lot of superior sulcus deformity, and many times we actually lose it or can miss it in our preoperative assessment, we must rule out any other orbital fracture or other pathology where the orbit has actually expanded in volume, and that needs to be taken care of to give good volume replacement. Migration of the implant, like in this child, we see the implant is inferior, can also cause a lot of issues with the fitting of a prosthesis. Now, how do you know that the implant is undersized? Suppose in this patient who already had a prosthesis in situ post-retinoblastoma enucleation, however, still has a deep superior sulcus with an obviously small size implant which is placed. Now, if you have to know whether further exchanging the implant with a larger size is going to help, a small test which we can do in the clinics is by checking for the compliance of the orbital tissue. If you just push the inferior part of the orbit and try to displace the posterior orbital fat in other tissues, and the superior sulcus gets filled up, that's a clue that further volume augmentation is going to take care of this deformity. Many times in post radiotherapy or other cicatrizing diseases, or there is multiple socket surgery, the compliance of the socket is lost, and just by replacing the volume or by replacing the implant, we might not be able to fill up the superior sulcus. Other things which needs to be noted, like in these congenital pathologies where there is a bony contraction, a hypoplastic contracted socket, we need to look for associated ptosis. We know that all anophthalmic socket will have some amount of ptosis, what we call as anophthalmic ptosis, which is essentially because of the volume deficiency and the loss of support to the levator muscle. Once we put the prosthesis in situ, that should get corrected completely. Many times, and prosthesis which is not maybe a small size prosthesis or not a well-fitted prosthesis can still cause some amount of residual ptosis, and when we give a good customized prosthesis, that is usually taken care of. But having said that, there may be some patient where there is an associated true ptosis, like we see in this patient who has a well-fitted prosthesis with good volume replacement, but there is still an upper eyelid aponeurotic ptosis, especially in cases where there were anterior staphyloma, where there has been a long-standing pressure on the levator aponeurosis, and post-operatively the patient can have aponeurotic ptosis, which needs to be identified and corrected. Now, volume deficiency management, Dr. Ishan has covered the implant part. I will not go into the details of it. Just to emphasize the fact that when we are putting an implant, it's very important, whatever implant we choose, it's important that the size is adequate, it is placed centrally within the intracorneal space as posterior as possible, and it is well covered with a nice healthy conjunctiva to have a good cosmetic outcome. Now, if you see this patient who already has an implant in place, there was an obvious orbital fracture which had been missed by the surgeon possibly. The implant is visibly small sized, not really going to replace the orbital volume. And with this fracture, again, with expansion of the orbit, this will need further volume augmentation. This is a small video just to emphasize the secondary implantation procedure post-evacuation. We have spoken about the primary implantation. Here, the important point to emphasize is that once we open up the scleral flap post-evisceration, we usually find a layer of granulation tissue on the inner surface of the sclera, especially if the surgery is done, say, within 6 to 8 weeks post-evisceration, which can be easily peeled off as a separate layer. And once we peel it off, the scleral flaps are nice and healthy, and we can easily get nice posterior sclerotomy and good scleral flaps. And the implant can then be placed within the intraconal space after doing posterior radial sclerotomy like was done for these patients. So this is something we need to know when we're doing a secondary implant. Dummy fat graft, again, we know it's a something known as a living implant. It's very good for post-irradiation sockets. It's good in children, and it helps in growth of the orbital tissue. And the good part is that it grows with the growth of the orbit. So we don't normally choose a DFG for routine socket. It's only in patients who have volume and surface loss together, like failed multiple socket surgery, chronically exposed implants where there is a lot of scarring in the socket. So basically difficult socket are the cases where a DFG is the implant of choice. These are the steps of how we do a dummy fat graft. We have to prepare the host bed by doing a horizontal conjunctival incision, expose the orbital fat. It should be a nice, healthy looking orbital fat, and make some space for the DFG to go in. The first step here is to put the fornix forming sutures. I'll come to the technique of it. And once we put the fornix formation sutures, both in the upper and the lower eyelid, the central area we measure, that is going to be the area which is going to decide what size of DFG we are going to harvest. The best place to harvest is from the upper outer quadrant of the gluteal area. We debride the epidermis, and this can be done either using a you can use a blade, and injecting your local anesthetic beneath the epidermis and giving this PUD appearance, orange appearance, helps in debriding the epidermis and getting a healthy dermis. We incise the dermis and we take out the required amount of fat. The important point here is that we don't want to overfill the orbit, so we don't use excessive amount of DFG. We just use the amount which is sufficient, and the edges of the dermis is then tucked to the edges of the conjunctival defect which we have created. So that is about the DFG. About the surface, the various options which we have depends on what is the amount of the contracture, what is the amount of surface contracture that we have. In very mild cases where there are small bands of conjunctiva, just snipping off those bands is going to be helpful. In cases like this, where there is something known as inferior fornicial shelving, which we need to differentiate from the inferior fornicial shortening, where there is a true cicatrization of the conjunctiva. On cursory evaluation, both might look same in the clinic, where there is loss of depth of the inferior fornix. However, in shelving, it's mainly because of the migration of the orbital fat and the tissues inferiorly that the fornix becomes shallow. But the conjunctival shortening is not there, so tucking the conjunctiva deep near the inferior orbital rim is going to take care of this problem. In this case, where there is a true shortening, the patient needs some kind of augmentation of the conjunctival lining. Fornix formation suture is used mostly in all socket reconstruction surgery. It can be used standalone only for cases where there is an inferior fornicial shelving without any scarring of the conjunctiva. Important point here is that while we take the suture bite, it's important to take your needle bite through the peri-orbita of the orbital, whichever fornix you're forming, either the superior or the inferior, so that your fornix gets its adequate depth. This is one of the patients, this is the immediate post-op, where you can see that once the shelving of the fornix is corrected, the prosthesis goes back to its position. For moderate to severe surface contracture, in cases like this, we have to resort to mucous membrane grafting, which is the time-tested procedure used for giving adequate surface to the socket. This is again a short clip of the surgery. We give a horizontal conjunctival incision. We undermine the conjunctiva till the fornix, so that these two flaps of the conjunctiva can now go back into the fornix and become part of sort of the palpebral conjunctiva. Fornix formation suture can be passed either before harvesting the graft or after harvesting the graft, depending on the size of the defect. If you have adequate conjunctiva.
Time's up.
Okay. So this is the same technique like what we have used. And after that, the graft is harvested from the buccal mucosa and it is defatted to some extent, and then you suture it in place with the use of interrupted sutures to the edge of the residual conjunctiva. A little bit about the use of anti-metabolites. 5-FU is now being used as a subconjunctival or sub-graft, sub-MMG injection in cases of early cicatrization of the surface, especially in recurrent cases where you're doing a resurgery, and it has been found helpful to prevent a recurrence of the surface contracture. These are some of the patients where we have used it, and we are able to get a decent fitting of the prosthesis despite having repeated surgery. Eyelid deformity needs to be taken care of, like in this patient who had chemical injury with a bad cicatrized surface, lot of seminiferon, bad eyelid, entropion, non-seeing eye, finally landed up with an evisceration, but still the surface was shallow despite doing a mucous membrane grafting, especially the superior fornix. So here, instead of putting further MMG, we decided to lengthen the eyelid by putting a cartilage graft, which gives an additional surface for retaining the prosthesis. Now you can see the position of the eyelid being corrected with additional augmentation of the surface, and which helps in retaining a good prosthesis following the correction of the eyelid deformity. Lastly, the cases of malignant contracted socket like this, there is no point in doing any surgical intervention, and the best thing to do would be to fit an exenteration prosthesis for this, like Dr. Neelam had shown. Before fitting a prosthesis, patient might need some surgical intervention to do a permanent tarsorrhaphy or to kind of cover the surface with a smooth graft. So as required, depending on each case, we can decide what intervention is required. So this is just to summarize the algorithm based on the surface contracture and the volume deficiency. If the surface is predominantly the one which is involved, we need MMG, FFS, and other eyelid lengthening procedures. If there is an associated volume loss, then DFG is the treatment of choice. We can always do an MMG on top of DFG after the healing is complete. If it's mainly the surface issue with not much of volume issue, then some amount of prosthesis modification, use of fornix formation suture, and sometimes use of amniotic membrane grafting can just suffice to get a good socket which can retain a prosthesis. So thank you for your attention.
Thank you very much, Doctor. That was a lovely talk. Dr. Vidya, would you have one question before we move on to our next speaker? We are really running short of time.
Well, actually, she has covered everything. I don't have to actually ask anything more.
Very thorough talk.
Very well presented. Thank you.
Thank you.
Our next speaker is Dr. Devjyoti Tripathi, who will dwell on orbital trauma, how to approach it. He's a consultant ophthalmologist and faculty specialized in ophthalmic plastic surgery and facial aesthetics and ocular oncology at LVPI, Bhubaneswar, with keen interest in retinoblastoma, eyelid and orbital tumors and reconstructions, and is also the coordinator of the DNB residency program therein. On to you, Doctor.
Is my screen visible and am I audible?
Yes.
Thank you, Dr. Chitra, for the introduction and for the opportunity. That was a very long introduction. So I was asked to talk about how I approach cases of orbital trauma. So what I set about doing is trying to provide a very basic sort of guideline that would be useful to residents who are there in an emergency room when an orbital trauma case arrives. So here we go. So when we talk of the orbits, let's get familiar with just a little bit of basic anatomy. And the orbits are basically bones which are in the shape of a cone with a truncated apex. So that's the cone and that's the truncated apex, which is located posteriorly. And when you look at the orbits on face, the rims are actually slightly discontinuous spirals where they are broken by the supraorbital notches. And as ophthalmic surgeons, when cases of orbital trauma come into us, we generally concentrate on that area. And we really do a good examination of that area. What we sometimes tend to miss is that and that area. So we need to understand that the orbit is in close contiguity with the skull, vault of the skull superiorly, and the mid face and the lower face inferiorly. More importantly, the mid face, less importantly, the lower face. So those are the bones which make up the orbit. The point here that I would try to make is that there are many bones which go into the contouring of the shape of the orbit. There are multiple suture lines, and trauma would usually involve more than one bone. So we need to be aware of the fact, and that the bones are supported by buttresses which provide the strength. There are buttresses which are vertically distributed in the face, laterally, medially, and there are buttresses which are distributed or aligned horizontally on the face. The red lines here, one in the lower mid face, one in the mid of the mid face, and one along the frontal bone up there. There are also buttresses which are located posteriorly, which are going from the maxilla through the pterygopalatine region. This is just a very, very brief idea of how the buttresses lie and how they support the midfacial skeleton. And these are the supports which are breached when you have fractures. Additionally, we have a lot of muscles which are attached to the facial and the orbital bones. And there are some areas where the muscles are very densely attached. There are some areas like the lateral part of the zygoma here where the muscles are not very densely attached. The consequence of this when trauma happens is that multiple muscle attachments generate multiple vectors on the same fractured segment when there is a bony fracture. And areas which have less muscular attachments and less support tend to get more easily displaced, like you would see in a zygomatico zygomatico fracture, maxillary fracture. Now, apart from the muscles, inside the orbit, we have a complex system of soft tissues, which includes a lot of things: muscles, bones, nerves, vessels, the lacrimal gland, and most importantly, the eyeball. And what we need to understand here, basically in this anatomy, is that this soft tissue, a part of it lies in the orbit, and the other part actually is an extension and is in contiguity with the brain or the intracranial cavity. So this has important implications when trauma is sustained to these structures, right? So with these very basic anatomic introduction, when an orbital trauma patient arrives in your emergency room, it is very critical to do the initial patient assessment. It is most important to see the consciousness levels, where the Glasgow Coma Scale scores help us. Then to check for the blood pressure. The systolic pressure is critical to tissue perfusion. The breathing, the respiratory rate, the effort the patient makes in breathing, and very importantly, to eliminate presence of polytrauma. It is good to examine the patient from the head to the torso to the extremities in sequence, so that once you recognize polytrauma, the right kind of triaging can be made. This list that I've presented here is very loosely based on the ATLS, the Advanced Trauma Life Support Guidelines that the American College of Surgeons provides. The document is available online, and anybody who's interested can go through the detailed guidelines. Once initial patient assessment is made, we come down to the actual assessment of the anatomy of the injury. So whether it's in the orbit, the face, the head, or the eyeball. And once this is done, then we go on to assess the mechanism of the trauma, the evidence of the impact, the probable velocity, and the damage it has actually caused. So when there's an acute trauma in front of you, these are the common features that you would find. Periorbital ecchymosis and subconjunctival hemorrhage are the commonest signs. There can be restricted ocular motility. There can be proptosis in ophthalmos. There can be bony soft tissue crepitus that you can see here from subcutaneous emphysema. There can be other features like hypoglobus, and there can be major associated soft tissue trauma like this. And the grossly displaced fractures will be evident even in acutely presenting cases, though they may many times be actually not so easily discernible due to overlying soft tissue trauma, overlying soft tissue edema in the acute stage. One of the most important things for us is to assess the eyeball and the vision. And it's not an easy task to do, especially with patients who have polytrauma and with patients who have neurological signs and symptoms. So we need to ask this important question: is there an ophthalmic emergency that we are dealing with, apart from the obvious orbital trauma that's there in front of us? So if there is proptosis, tense eyelids with difficulty in opening, gross inferior globe dystopia, we have to think of retrobulbar hemorrhage, orbital compartment syndrome, or a subperiosteal hematoma. If we come across an afferent pupillary defect, traumatic optic neuropathy, optic nerve sheath hematomas, and optic nerve avulsions need to be considered. And if we have crepitus over the periocular soft tissues or proptosis, massive subcutaneous or orbital emphysema needs to be considered. Other than this, we always have the eyeball-related trauma like an open globe injury, vitreous hemorrhage, retinal detachment, hyphema, and intraocular foreign bodies. All these will come under ophthalmic emergencies, and these have to be looked for specifically along with the periocular and the orbital trauma. Old trauma generally presents with enophthalmos, restricted ocular motility, hypoglobus, facial asymmetry from obviously displaced fractures, and there can be persistent infraorbital hyperesthesia. So CT usually is considered the gold standard for imaging. These are the things that Dr. Savri Desai will take up in a much more elaborate manner in her next talk. So we generally look for discontinuity in the contour of the orbital walls. I'm just going through what should one look for in a CT in common trauma cases. And this is the typical teardrop sign that one can see here with intraorbital air or pneumoorbit, and of course the prolapsed fat. So floor fractures can often be associated with hemosynus, and medial wall nasal fractures can also be associated with hemosynus and very obvious subcutaneous emphysema there. Entrapment is found in several cases. In this case here, we actually see the prolapse of an orbital fat and a rounded contour of the inferior rectus muscle, which is edematous and swollen up due to the trauma that has been sustained. And in this case, we see the typical missing inferior rectus muscle syndrome, where you can trace the inferior rectus muscle till here, and then it's entrapped in a trapdoor fracture. It does not seem to be continuing beyond this point. Foreign bodies need to be eliminated, looked for, and sometimes they can be as obvious as that one. Sometimes they won't be obvious at all. As in this case, we just found grossly restricted elevation in this patient, and the scan showed up this foreign body. It's a wooden intraorbital foreign body. These are again notorious for being interpreted as air on imaging. And then this is the intraoperative picture of the foreign body being removal, and it was about 7 centimeters long. And on seeing, thanks. So should imaging be done in all cases? It is an important question that we often ask ourselves, especially as beginners. So let's look at this case. This was a fist injury. You can see ecchymosis, subconjunctival hemorrhage, elevation complete, but the patient had a small fracture there. So these small fractures can generally be left alone. 3 years later, the patient is doing well. So imaging can be resorted to in any case that you have a doubt in, or the mode of trauma suggests that there is a high probability of fracture. So this is a small clinical checklist for trauma. Check the history, the mode of trauma, if there is a loss of consciousness, nosebleed. Check symptoms if there is altered sensorium, diplopia, vision loss, pain on opening the mouth. Signs, orbital rim continuity, periorbital soft tissue crepitus, globe position, ocular motility. This is basically a list of what we just went over, but in the form of a checklist that helps you go through everything so that you don't miss important assessment. Imaging checklist, make sure the CT scan is done the way you want it done. Ask for soft tissue and bone windows and different cuts, and 3D reconstructions if complex fracture is suspected. Apical cuts if traumatic optic neuropathy is suspected. Make sure the scan is read meticulously. Go through each and every part of the scan, the bony contour, the soft tissue, the adjacent PNS and the brain, and presence of air in abnormal locations, and make sure to exclude foreign bodies. And imaging findings should be correlated with severity of clinical findings, as we are always taught as fellows, treat the patient and not the scan. And if there is any case of complex trauma, do not hesitate to seek multidisciplinary consultation. Thank you.
Thank you very much for a lovely, crisp and brief talk, Doctor. I have one question to Dr. Ashok in the relation to this. What would be some very signs we need to look at when we are dealing with an orbital fracture, Dr. Grover?
Chitra, the first thing is that, as was emphasized by Debajyoti, you look at the patient as a whole. Any trauma case often has systemic injuries, and you need to make sure that all those aspects are taken care of before you look at the eye and orbit trauma. And working with teams is very important because it's often usually a pan-facial trauma. So that is one of the basic things. Then, of course, there are the specific signs of fractures, which I'm sure Savri will be dealing with in orbital floor fractures. But it is important, again, to look at all the four walls. It's become increasingly important that we restore the volume of the orbit and restore back the contents to their normal position. And that is why increasingly we realize the importance of the posterior ledge and intromedial ledge and trying to restore back the orbital volume mirroring the other side. So you need to ensure that you not just take care of the floor, take care of the medial wall fractures, any displacement of the lateral wall, and so on, so that you restore back the anatomy to the best. And that's where the newer techniques where you do a mirroring and do a 3D printing of the other side to make your plans and use customized implants and increasing use of titanium plates, etc. These have all come about as the understanding of the orbital fractures and their management has grown. I'm sure specific signs Savri will be dealing with very well.
Vidya, you have anything to ask?
Yes, madam. Like if we have a patient with intraocular trauma, intraocular emergency, like a retinal detachment, and we need to post that patient for surgery along with an orbital fracture. Do we have to stage the procedure, or does that change our line of management? Do we have to pay attention to the technique of anesthesia in order to prevent compartment syndrome, or how do we go about that?
I think most orbital fractures can wait a little, and except if it is a muscle incarceration like a white-eyed fracture. Most other cases can wait. And if I were to deal with a problem like retinal detachment, I would do that first and go on to orbital problem later. In any case, if you have an open globe injury and an orbital injury, I would deal with the open globe injury. You could, at the same sitting, do an orbital fracture if it does not involve too much globe manipulation. But the priority always would be the globe restoration before you undertake an orbital repair. You could stage it, you could do it in the same stage, but for a thing like retinal detachment or something, you would do the retinal detachment, wait a few days. Most orbital fractures can wait a few days.
Thank you, Doctor. Our next speaker is Dr. Saviri Desai, who's going to talk on blowout fractures management. She's a consultant in oculoplasty, ocular oncology and aesthetics at Hinduja National Hospital, Mahim Hinduja Healthcare, and Breach Candy Hospital. So on to you, Doctor.
Thank you, Dr. Chitra, AIOS, Dr. Santosh, for inviting me to speak here. And I'm looking forward to, this talk with all these panelists. I'll just share my screen. Am I visible?
Yes, Savri, you are.
Okay, thank you. So I'll be speaking on blowout fracture management, which is a rather large topic to cover. I think Devjyoti did a really good job of the how we approach it. But since this covers a large spectrum, I've taken out the salient fractures and the importance associated with them. So, so what is the exact formula which really works? Is there a formula for this, which is, sorry, I'm just going to, my screen is not showing up for me, sorry. Okay. Okay, so what is the formula that works? So it's a very simple thing on the basis of type of fracture, the timing of repair, the principles of repair, and the surgery itself, which gives us a functional and a cosmetic result. So fractures are broadly classified into pure fractures, such as the one where you see a red arrow, which is only a floor fracture not involving the rim, or the one on its right side, which involves the floor and the rim, which is also known as impure. Then you have tripod fractures, and then you have facial fractures, which involve Le Fort fractures and nasoethmoid fractures. But blowout fractures can further be classified into isolated fractures involving only one wall, fractures which involve more than one wall, as is seen in this case in the right side medial wall fracture, two walls, such as medial and inferior, and again, tripod fractures, which involve more than two walls. In most cases, CT scan, as Devjyoti mentioned, is the modality of investigation. But in case there is an intraocular foreign body or any foreign body suspected, then in the history, you need to take this and consider doing an MRI. So what are the recommendations for repair? So the recommendations are broadly classified, as most have been taught in undergraduation, as immediate, within 2 weeks, but I've made it 2 to 4 weeks, and post 4 weeks, which is considered a late repair, and observation, which will come to as case-wise. The principles of fracture repair as such are based on certain principles where you mobilize the soft tissue which is herniated, either the fat or the muscle itself, the repositioning of the framework, and the reconstruction of the orbital walls with implants. Along with this, a couple of things that you need to check is the nasolacrimal duct for any obstruction, also maxillary fractures, which are almost always involved in mid-facial fractures, and also intraorbital anesthesia, which may be a very subtle but important finding, which involves the lower cheek and the teeth. Most approaches are done using an hidden incision, which is an inferior fornicial incision. We move, at least as oculoplastic surgeons, we have moved away from doing subciliary incisions, but yet a lot of plastic surgeons still do those, and hence we see late onset lower eyelid retraction, which will be quite severe and cosmetically disfiguring. While there are many implants, autologous and synthetic, these are my implants of choice. There is porous polyethylene, then there is a titanium mesh with porous polyethylene without, silicone, which can be available as blocks or as just simple plates in different sizes or sheets. So I prefer to use porous polyethylene titanium, and of course, these are synthetic implants. You can mold them, you can cut them to the right size. Titanium has a higher cost, but it works well for certain types of implants, which we'll come to. As far as silicone goes, I used to use it a lot in my initial days of practice. I still do it. I use silicone block when it involves large enophthalmos. Regarding bone, which cannot be just ignored, a lot of plastic surgeons, most plastic surgeons prefer bone. I have not been taught with bone, and though I did accompany and assist for a couple of surgeries, combined surgeries with plastic surgeons for bone, it's not something I prefer doing, as I've seen that my results in my hands work with these implants. So the important thing is to also figure out an implant that works in your hands and not just in what has been advised to you over the years. So coming to cases, so we take a simple thing as a classical isolated floor fracture with a teardrop sign, restriction of movements in the vertical gaze, enophthalmos, and an entrapped fat or herniated fat, which is pulling on the inferior rectus. Occasionally, you have to also ask for an oculocardiac reflex or the patient themselves might give a history of an oculocardiac reflex. Here you can see very clearly the classical teardrop sign. This patient underwent a simple floor fracture repair, taking care of her diplopia, enophthalmos, and give a cosmetically good result. You can have medial wall fractures, which occur in about 7 to 40%. And as you can see here, unfortunately, my cursor is not working, but it's the left-sided orbit. You can see she has enophthalmos, and also there is herniation of the medial rectus. So most medial wall fractures can be left alone, but in cases where there is a horizontal restriction of movement and diplopia, either in abduction or adduction because of entrapment of medial rectus, those need to be intervened early. Medial wall fractures are also known to often present a little late, so as to initially the medial rectus does not seem like it's going to be causing any problems. There's no enophthalmos, but maybe after 2 weeks you may find some amount of enophthalmos, and that is usually requires to be addressed, but entirely depends on the patient. So we've had elderly patients who've not addressed that, as it did not cause any diplopia. This is the same lady who had a repair. I used porous polyethylene. You don't need to use any additional thing, but I did use glue to just keep it in place since it was a medial wall. The main thing about medial wall is to cover the entire defect in its toto. If you don't, and you leave, as is seen on the right-sided photo in arrow, and you do not go right up to the posterior side, eventually you may get a reherniation. So let's take a miss of mine, which happened in my early years. An inferior and a medial wall fracture can be seen. The medial wall, the medial rectus is herniating. I have repaired it, and as you can see, there is still a subtle amount of enophthalmos, and this is post-operative at 2 years. So what went wrong? So as you can see, the inferior rectus orientation is very horizontal. The floor has healed, but you can see that the medial rectus is still herniating into the fracture. So I used a silicone sheet, which I swung over the medial wall and the floor, and it has slid down over the years and caused the medial rectus to herniate again with no diplopia. But yes, she was not happy about the enophthalmos. So you have to be careful about using the right amount of implant. Coming to another isolated fracture known as the white-eyed blowout fracture, which needs early repair, commonly seen in children, very trivial injuries such as a fall, bicycle handles, and the patient will be only realize that something's wrong on the 4th or 5th day, or even the 7th day, as is seen in this young 7-year-old boy who realized something was wrong and he could not see clearly. It was diplopia, obviously. And you can see the red arrow is pointing to the inferior rectus, which is actually sitting in the maxillary sinus. These usually have been, they're typically known as white-eyed because there is no external injury and need to be repaired immediately. The entrapment has to be removed well, and the parents need to be informed that there may be some amount of diplopia which was.
What happened? Dr. Saviri?
Yes.
Talk is over? No, no.
No, no.
No,
As
but
my slide
I'm not seeing the screen anymore.
Oh, 1 minute, I think.
After you've stopped share, just reshare again.
Yes. Can you see it?
Yeah, yeah.
So this is the same boy in which the implant was placed, covering the defect, and he had no diplopia, but it took about almost 6 weeks to resolve. So this must be told to the parents, otherwise they get very scared. Coming to tripod or zygomaticomaxillary fracture, which is basically fractures involving 3 points of the zygoma. They have to be repaired immediately because, as you can see, they give rise to hypoglobus, diplopia, and significant enophthalmos. These can be done either on your own if you're confident of repairing the zygoma, or with a maxfax or a plastic surgeon. You have to reduce the zygoma, fix the orbital framework, either in a 2 or 3 point fixation. This is very important, or else you will end up again with a significant enophthalmos. Once you've reconstructed, you place the implant covering the defect. So this is the same gentleman at 2 years follow-up with no enophthalmos. And as you can see here, the plate is covering both the medial and the lateral extent and the posterior strut of the fracture. Now, when we use any isolated or two-wall fractures such as inferomedial, it is absolutely pertinent that the implant reaches up to the posterior strut. So this is a gentleman who came to us because he was told that he did not need repair. And as you can see with the orange arrow, there was a fracture and the orbit looks a little larger. So this is at 3 weeks, he had developed enophthalmos and was told that initially he would not repair just because there was no herniation of the muscle. So in cases like this, which is not a very large fracture, what you could do is call the patient and observe him on a weekly basis.
We can't hear you.
Ma'am, the connection dropped, I believe. There is some disruption which is happening.
So,
can you hear me now?
Ma'am, your presentation stopped and your connection also stopped.
Yeah.
But I don't know why that's happening. I have a full connection. Yeah, I'll conclude. Just give me a minute. So coming to the last, that is the post-traumatic enophthalmos. This, as you can see, this lady's maxillary fractures were repaired and connected, but was told that she did not need anything for the orbit, and she developed 7 millimeters of enophthalmos. In this case, where you have to take care of such a significant enophthalmos, firstly, you have to cannot promise the patient that you'll be able to get absolutely, equal results. You may have a little residual enophthalmos, and you would like to get a 3D CT and review the entire thing, and maybe even do, like Dr. Grover said, just a sort of a imprint of the other orbit. So in this case, we did get almost near results. She does still have about 1 millimeter enophthalmos, and I used a titanium mesh covering all the way from her medial wall to the floor. Coming to the last slide, which is an isolated orbital flaw fracture. In these cases where there is, as you can see, there is a fracture in the right orbit with a little herniation. We have observed him till 4 weeks, no diplopia, no herniation, and no surgery required. So each fracture has its own cost. Document the extent of the injury. Choose the implant that works in your hands for the fracture. And as Dr. Grove very rightly said, combined team effort is a win-win situation. Thank you. I'm sorry about the connection.
No, thank you very much. But I think I'll have to hold on with the questions and first hear our speakers. Moving on to ocular oncology, we have Dr. Pratibha Devi talking on a child with white reflex, evaluation and diagnosis, who again leads the orbit and oculoplasty department at the MNI hospital, with her area of interest being thyroid eye disease. On to you, Dr. Pratibha. Pratibha, try to stick to time. Are you unmuted? Dr. Pratibha, you need to unmute yourself.
Good evening. I thank Chitra Madam and the organizing committee for giving me an opportunity. And my talk will be on a child with white reflex, evaluation and differential diagnosis. So leukocoria means white pupillary reflex. So literature says that retinoblastoma has to be considered as the first differential unless proven otherwise. And there is another term called pseudoleukocoria, which means white reflex which is present intermittent, and it can be because of the reflection due to the optic disc. The differential diagnosis for leukocoria or pseudoretinoblastoma could be because of various pathologies in the lens, that is the cataract, the pathologies in the vitreous cavity, and pathologies in the retina like the coloboma, toxocariasis, familial exudative vitreoretinopathy, retinopathy of prematurity, retinal detachment, and retinal astrocytoma. So evaluation includes a proper detailed history taking, torchlight examination, intraocular pressure measurement, anterior segment evaluation, fundus examination, ancillary testing, and imaging. So in history taking, the age of onset is very important. So the parents has to be inquired about the right age of onset. Literature says that the average age of onset for retinoblastoma is 1.5 years, whereas in Coats disease, the average age of onset is 5 years. And duration of onset can also be evaluated by seeing the serial photographs by getting it from the parents. And other symptoms has to be also inquired from the parents about the presence of squint, defective vision, and others. A detailed past medical history has to be obtained, and this includes a history of retinopathy of prematurity, because such kids can present with retinal detachment in the later age. A history of ocular trauma should be elicited from the parents, because that can children with earlier ocular trauma can present with rhegmatogenous retinal detachment causing a white reflex later. History of arthritis and juvenile idiopathic arthritis should be elicited from the parents. History of prenatal infection should be elicited. Exposure to pets to rule out Toxocara infection should be done. A detailed systemic illness history should be elicited, particularly tuberous sclerosis, which can cause retinal astrocytomas. And skin disorders like incontinentia pigmentae, which can cause multiple vesicles in the skin, which can be associated with rhegmatogenous retinal detachment. Family history of certain diseases which can cause leukocoria should be asked, such as retinoblastoma, familial exudative vitreoretinopathy, and coloboma. Clinical evaluation includes detailed torchlight examination. Here we see a symmetrical red reflex, but in this picture we see absence of red reflex, which denotes there is some pathology in this side. And here we see a chalky white reflex, which indicates there is a tumor, and chalky white or a white leukocoria is suggestive of retinoblastoma. Yellowish tint or a xanthocoria is indicative of Coats disease. And in the third picture, we see a bluish white reflex, which is characteristic of a cataract. Next, the pupillary evaluation has to be done, and then the visual acuity examination has to be done for both verbal and non-verbal children. For verbal children, the Snellens, and the non-verbal children, we can use the Lea symbols. Intraocular measurement should be done by using non-contact methods, as we are dealing with children here, and intraocular pressure can be raised in retinoblastoma, Coats disease, and juvenile idiopathic arthritis. It can be low in retinal detachment. So when we see, then a detailed anterior segment examination has to be done using a slit lamp. When we see a picture like this, opacity in the posterior capsule of the lens with a fetal vasculature, a remnant of the fetal vasculature, and which can be present along with microcornea, microphthalmia, shallow anterior chamber, and then we should strongly suspect a persistent fetal vasculature. This is a Burgmeister papillae showing the white reflection here. When we see a patient like this with a bluish white reflex, we should evaluate the lens for cataract, and the diagnosis of congenital cataract was made after ruling out any mass lesion in the retina. This is a very quiet eye. There is a presence of hypopyon in the anterior chamber, but the anterior chamber also had fluffy seeds on the iris. So this patient is a case of anterior chamber retinoblastoma with pseudo-hypopyon, and the presence of tumor in the vitreous cavity and the retina has to be done. When we see something like this, a mass lesion protruding in the through the pupillary reflex, we should also evaluate for the presence of cataract, glaucoma, and the possibility of a ciliary body medullary epithelioma has to be made. So this is a case of iris coloboma, and iris coloboma can present with a cataract in the earlier days, and it can cause a white reflex. And when the iris coloboma is present along with the choroidal coloboma, the reflection can cause a leukocoria. This is a picture of anterior chamber, which shows shiny golden shiny crystals in the anterior chamber. This is called as cholesterolosis, and this indicates a benign chronic retinal disease, particularly Coats disease. And when we see a picture like this, we know that there is some chronic inflammation in the eye along with some band-shaped keratopathy. The diagnosis of juvenile idiopathic arthritis has to be made, and this is present along with the cataract, and that is the reason for the white reflex here. And this is yet another case of anterior chamber retinoblastoma. Once we do a thorough anterior segment evaluation, we have to see into the vitreous cavity. So a retinoblastoma can present with vitreous seeds, as we can see here, and it can cause a hazy media and fluffy vitreous deposits like this. This is a very nice picture of a persistent fetal vasculature where there's a communication, persistent hyaloid artery connecting between the optic disc and the lens. Presence of vitritis can cause a hazy media and a picture like this, and can cause a dull reflex. So optic disc findings like morning glory syndrome and retinochoroidal coloboma can cause a white reflection causing a leukocoria. A detailed retinal evaluation has to be done, and the retinoblastoma has to be a detailed retinal evaluation has to be done. The presence of multifocal tumor should be ruled out, because a 360-degree evaluation has to be done. And presence of a retinal picture like this, like in a headlight in fog appearance, should give us a clue about Toxocara infection. Familial exudative retinopathy usually do not cause a white reflex in the initial phase. In the initial period, they only cause straightening of the peripheral vessels, along with ischemia or ischemia and neovascularization of the retina. In the later phases, the neovascularization can cause exudative retinal detachment, and that can cause a white reflex. Retinal detachment is very common differential for retinoblastoma, and this is a rhegmatogenous retinal detachment, and exudative retinal detachment, as in Coats disease, can also cause a leukocoria and confuses between a tumor. So after doing a thorough clinical examination, sometimes we might not come to a conclusion about the diagnosis, and we have to do certain ancillary testing to come into a diagnosis. And ultrasonography is the best tool, which is easily available, not expensive, not invasive. It is easily accessible, and it is very highly specific to detect retinoblastoma and to see for calcifications. These are some of the pictures of ultrasound depicting the retinoblastoma. The first picture, it is a multifocal tumor. There is 3 elevated dome-shaped lesions which are homogeneous. And in the second picture here, we see a single tumor elevated lesion from the retina. Here we see multiple calcifications in the mass lesion. This is very peculiar. These calcifications are very peculiar of retinoblastoma. This is an ultrasound picture of a persistent fetal vasculature wherein we see a communication, the beautiful communication between the disc and the lens.
Doctor, 1 minute left.
A rhegmatogenous retinal detachment can be easily picked up by the separation of retina from the other layers. And Coats disease can sometimes confuse us with the mass lesion. To differentiate a Coats disease, we can do an imaging to come to a conclusion. UBM is taken particularly in choroidal tumors. And angiography is not done for all the cases, but when there is in retinal disorders causing a white reflex, we can do angiogram, particularly in Coats disease and in toxocaral infection. MRI is the diagnostic of choice when we doubt a case of retinoblastoma. We should do a MRI to see for the extent of tumor into the optic nerve and to the infiltration of the tumor into the intracranial cavity. We should also see a presence of tumor in the pineal gland to rule out trilateral retinoblastoma. So this is MRI pictures of cases of retinoblastoma. This is an axial picture. This is an T1 weighted image. Here we see proptosis with mass lesion, which is iso-intense in T1, with extension of the tumor into the orbital cavity and in the optic nerve, and is also extending into the brain. And this is a T2 weighted picture of another patient, wherein the T2 weighted images show a hypo-intense lesion of mass lesion, but there is no extension into the nerve and brain. How to differentiate between an exudative retinal detachment and retinoblastoma? Exudative retinal detachment will be iso-intense in T1 and will be will be hyperintense in T1 and will be iso-intense in T2. And other blood, apart from the routine blood investigations, torch testing has to be done in patients with leukocoria. And genetic testing will be should be done, particularly when we deal with retinoblastoma and astrocytic hematoma. And Honavar sir and Usha madam will be talking about that. And fine needle aspiration biopsy should only be done after ruling out retinoblastoma, and for us to get a clear diagnosis when we are not sure about the diagnosis, an AC tap or a vitreous tap can be done for further diagnosis. So to conclude, we have to examine this any child with leukocoria with an open mind, think of all the possibilities, and examination under anesthesia should be done if the child is small. Thank you, AIOS, for the opportunity.
Thank you, Dr. Pratibha. That was a very thoroughly dealt differential diagnosis. We shall now go on to Dr. Santosh Honavar, who's going to be talking on advances in retinoblastoma. And let's look forward to some highly charged next few minutes. On to you, Dr. Santosh.
Thank you, Chitra. While Pratibha shares her screen and I share my screen, let me congratulate you for conceptualizing a wonderful program and choice of speakers and the topics. Very good job. So I'll be speaking about the recent advances in retinoblastoma as Chitra has indicated, and try to stick to time. Well, if you look at this timeline, you see how impressive has been the success in managing retinoblastoma. We started off in 1900s with 98% mortality, and the trends are totally reversed in 2020 with more than 98% survival. This is possibly the only malignancy of all systemic malignancies where we could achieve this higher success. That's because we have been able to get a handle on the management of retinoblastoma by using several techniques. Of course, the primary aim is always life salvage, followed by eye and vision salvage as secondary and tertiary aims. What is new about retinoblastoma? We already are familiar with international grouping and staging. This is international grouping and staging, which have been there for several years already. But what is really new is TNM staging. This chart actually shows TNM staging, and some of this is asked in the exam. And something unique about TNM staging in retinoblastoma, which is not there for any other malignancy, is the addition of H criteria. T is for tumor, M is for metastasis, and N is for nodes. But H is never there for any other malignancy except retinoblastoma, so that's something unique. What about focal therapy? Cryotherapy has good success for peripherally located small tumors, which are about 3 to 4 millimeter in diameter and 3 to 4 millimeter in thickness. It produces a large scar, which may not be acceptable if the tumor were to be located on the temporal aspect, or if there is any risk of, say, epiretinal membrane over the macula, if you were to do cryotherapy to a kind of tumor which is located not exactly in the periphery, but more towards the center. Laser photocoagulation is not acceptable because it produces a very large scar, because laser is performed around the tumor and not on top of it. Also, it can cause vascular occlusion, as you see here, and of course, visual field defects, ILM rupture, and production of vitreous seeds. So what's really taken off in the management of focal tumors is transpupillary thermotherapy, where we laser on top of the tumor. This is sub-photocoagulation laser, which heats up the tumor to about 45 to 60 degrees centigrade, thus inducing tumor cell apoptosis. So classically, it does not produce a larger scar than you began with, and the blood vessels that pass through the tumor are quite patent. So minimal complications are seen with transpupillary thermotherapy. What is new in transpupillary thermotherapy is photodynamic thermotherapy, or ICG enhanced thermotherapy, where we use indocyanine green injection, and then on top of that do transpupillary thermotherapy, specifically in patients who have a non-pigmented scar. So this patient has a recurrence over a previous scar, that is a recurrence, which will not take up standard TTT well. So when you inject ICG, that causes synergistic effect, and with couple of sessions, you can see that the recurrent retinoblastoma is regressed. So this is absolutely new in the management of retinoblastoma. Plaque is not new, but the indications of plaque have changed with the advancement in the design of the plaque, especially notch plaque. We can reach the juxtapapillary tumor quite easily. Like this patient who has a juxtapapillary tumor, earlier we were not able to reach it with protection of the optic nerve. Now you can see nice results with protection of the optic nerve, which looks very healthy. And the tumor has calcified following this use of notch plaque. So there are specific indications for plaque brachytherapy, and what is new in the management of retinoblastoma using plaque brachytherapy is the Indian plaque, which is made by BARC, which costs less than 5% of the imported plaque, so it has become much more affordable. So for focal therapy, less is more, and what is new is, of course, ICG enhanced TTT, and what is on the horizon is transscleral strontium radiation, and also chemoplaque, which is already under trial by some of the groups in Canada. Chemotherapy brought about a paradigm change. These 4 articles in Archives of Ophthalmology, now JAMA 1996, brought about a change in the management of retinoblastoma from radiation to chemotherapy. Intravenous chemotherapy is become the standard of care, was the standard of care, I should say, at least in the West. Now it's changed over to intraarterial chemotherapy, but in India, it is still the standard of care where we use carboplatin, etoposide, and vincristine and get very nice results. As you see here, this large tumor becomes a much smaller scar. One more tumor here becomes a much smaller scar, and the macula fovea is very nicely exposed. And as the tumor regresses towards its feeder vessel, here the feeder vessel is supratemporal blood vessel, it leaves the fovea macula very early in the management course, thus maximizing visual potential. Intravenous chemotherapy still remains the standard of care in India. Whereas what has come about are various other forms of giving chemotherapy, such as high-dose intravenous chemotherapy, neoadjuvant chemotherapy or adjuvant chemotherapy, intraarterial chemotherapy, periocular and epibulbar chemotherapy using drug delivery systems, and intravitreal, and the latest is intracameral chemotherapy. Now, intraarterial chemotherapy technique is well known. It is injected into the ophthalmic artery directly by cannulating it using a 400 micron catheter. You peep into the ostium of the ophthalmic artery and then inject a series of 3 drugs. We use a combination of topotecan, melphalan, and carboplatin. Instead of using just melphalan, which is of course good, but you might have to give more number of cycles. When we combine it with topotecan and carboplatin, the success is much better with fewer number of cycles, thus saving a lot of cost and also reducing the sessions of anesthesia for these children. You can see nice results with intraarterial chemotherapy with triple drug protocol. Total retinal detachment settled with 1 cycle, a large tumor reduced to a much smaller scar after 3 cycles of intraarterial chemotherapy, and a recurrence on top of a prior calcified scar gone away nearly totally with 1 cycle. So this is really magical in terms of response, and for say a group B tumor, the success is 100%. In fact, all the tumors regress just with intraarterial chemotherapy if you were to use it for an early tumor. But generally, we don't want to use it for a group B or a group C tumor where we can simply use intravenous chemotherapy with equal amount of success. There's hardly any difference in success between IVC and IAC in group B and C tumor, but the success starts manifesting when you go to group D. Group D has about 50 to 60% chance of success with intravenous chemotherapy, whereas with IAC, success increases to 92%. That's a huge jump. And in group E retinoblastoma, success used to be with intravenous chemotherapy about 30 to 50%. Now there is much better success with intraarterial chemotherapy. And with secondary IAC, where you have failed intravenous chemotherapy, and then for a recurrence or a failed intravenous chemotherapy, you give intraarterial chemotherapy, success is excellent. So intraarterial chemotherapy makes a difference for group D and E retinoblastoma and for large recurrences or non-response to intravenous chemotherapy. Vitreous seeds were the major bugbear in the management of retinoblastoma. These are no longer vitreous seeds. We have many types of seeds in retinoblastoma now. This, of course, the classic vitreous seeds we always knew. Now, based on OCT, we can classify these as prehyaloid, subhyaloid, and epiretinal. On top of that, there is something called intraretinal, subretinal we always knew, and then intracameral. Intracameral is further classified as depository when the seeds come through the zonules and settle in the anterior chamber, and infiltrative when there is contiguous extension into the anterior chamber by ciliary body, peripheral iris, and the angle. Now, how do you manage these vitreous seeds? Intravitreal chemotherapy has become the standard of care for the management of vitreous seeds following regression of intraocular retinal tumor. Basically, you wait for the retinal tumor to nearly totally regress, then only you start injecting. You can see nice results with these focal vitreous seeds completely gone with melphalan. We used melphalan initially, but we started finding that with more and more injections, we have this problem of RPE atrophy and also vascular occlusion and scarring. These also leads to uveitis, cataract, and needs weekly injections as opposed to 3 weekly injections with topotecan. So because of better bioavailability and much better success with fewer number of injections, we have shifted to intravitreal topotecan. You can see nice results with diffuse vitreous seeds with intravitreal topotecan. All this child needed was a couple of injections. There's one more situation where there are seeds completely gone with 2 doses of intravitreal topotecan. Patients need anywhere from 2 to 6 doses of intravitreal topotecan to get this kind of success. And when it doesn't happen, when there are refractory vitreous seeds, despite 6 injections of topotecan, like we started off with this huge number of vitreous seeds, after 6 injections of intravitreal topotecan, we still had residual vitreous seeds which are refractory. Then we add low-dose melphalan and they go away. But note that retinal pigment epithelial atrophy has set in with melphalan. So melphalan does have complications, but when you use it in low dose, 10 or 20 microgram, the complications are much less. Excellent success with intravitreal topotecan was reported earlier. Now what we have is extended indications. Patients with anterior segment seeds were earlier straight away enucleated. Now we give them the benefit of eye salvage by injecting topotecan intracamerally. Thankfully, it is not toxic to the corneal endothelium, and you see clear cornea with the anterior chamber seeds gone with topotecan. One more example where there is a complete regression of anterior chamber seeds with a couple of injections of topotecan. When there is infiltrative retinoblastoma with anterior chamber extension because of ciliary body invasion, as you see here, you can do plaque brachytherapy for the ciliary body component, and for the anterior chamber seeds, you can inject topotecan. With this combined modality, there is better success. One more use of intravitreal topotecan is for extensive subretinal seeds. We never thought that this would be the response for subretinal seeds, but you can see all these extensive recurrent subretinal seeds are gone with intravitreal topotecan without any laser. One more situation where all these extensive subretinal seeds, which would have earlier lasered and caused a lot of retinal scarring, were completely gone away with intravitreal topotecan. So retinoblastoma seeds seem to have been finally conquered. We all know about the technique of enucleation and the importance of taking a long optic nerve stump, but something that must be followed following enucleation is the identification of histopathological risk factors. We seem to have a very high chance of having histopathological risk factors. Almost half the patients who undergo enucleation have this. And for them with anterior chambers, anterior segment invasion, ciliary body invasion, choroidal invasion of more than 3 millimeter in diameter or 3 millimeter in thickness, or optic nerve invasion beyond the lamina cribrosa, we provide adjuvant chemotherapy. All these children receive 6 cycles of adjuvant chemotherapy, and the results are very evident. You see that without adjuvant chemotherapy, they have 24% chance of developing metastasis. Whereas if you give adjuvant chemotherapy, you can save about 20% children. So chance reduces from 24 to 4%, thus salvaging about 20% lives. So that's very important. So enucleation is not the end in the management of retinoblastoma. Finally, orbital retinoblastoma, it could be primary when the child presents with orbital retinoblastoma, either clinically or radiologically, as you see on MRI here, or secondary when the child develops retinoblastoma in the orbit following enucleation. It used to have 70% mortality with orbital exentration, as was done earlier. Now with a multimodal treatment protocol where we begin with neoadjuvant systemic chemotherapy, this orbital component goes away and the eye becomes thesical, at which point in time you would enucleate with a long optic nerve stump, deliver stereotactic radiation, and follow it up with adjuvant chemotherapy. This is used even for optic nerve extension, like this child who has optic nerve extension right up to the orbital apex, where enucleation would leave a residual tumor. You can use neoadjuvant chemotherapy to reduce the optic nerve component and then do enucleation. And for anterior intracranial extension, you can see that that's gone, and what is left is simply at the superior orbital fissure amenable to radiation. you can get very nice cosmetic outcome. Like this child with primary orbital retinoblastoma now can use a nice prosthesis. This is a child with secondary orbital retinoblastoma without needing orbital exentration. It's gone away. So orbital retinoblastoma now has a cure with about 90% life salvage. With all this put together, we have about 95% life salvage in our series. And you can see the contributors for this success in life salvage, of course, neoadjuvant chemotherapy, adjuvant chemotherapy, and multimodal treatment have together contributed to about 98% life salvage. Whereas for eye salvage, intra-arterial chemotherapy, intravitreal chemotherapy, and brachytherapy have played a role in increasing it to 80 to 90%. And for vision salvage, of course, we have intra-arterial chemotherapy, intravitreal topotecan and not melphalan, and ICG-enhanced transpupillary thermotherapy have contributed about 80 to 90% vision salvage. In conclusion, I would say that retinoblastoma management continues to be complex, but what is important is the use of cost-effective and protocol-based management strategies, which can help us get much better success. Thank you so much.
Thank you very much, Dr. Santosh. I have two questions for you. One is when you're doing intravitreal chemotherapy, how do you avoid tumor seeding outside the eye? The second question is if it's a bilateral retinoblastoma, would you, how do you rate doing a bilateral intraarterial chemotherapy?
Well, first question, what we do is we wait for the retinal tumor to regress. So that minimizes the risk of extraocular extension of retinoblastoma. Second, we use what is called a safety enhanced technique. We use a 30 or a 32 gauge needle, and then we enter from an area where there is no retinal tumor, inject, and without taking the needle out, we apply cryotherapy around the site of entry, and the needle comes out through the ice ball. So that kills any tumor cell, if at all it would have theoretically come out. Second is a death by water technique where you irrigate the ocular surface with normal saline for about 3 minutes. That is supposed to kill the tumor cells which have come out accidentally, if at all. And the third is subconjunctival injection of topotecan around the site of injection. And for bilateral retinoblastoma, we can do tandem intraarterial chemotherapy at the same session. It takes a much longer procedure, but then it is possible and we have done it.
Thanks a lot. Thank you. Vidya, you have any question or shall I go on to Dr. Usha?
Sir, any age limit, the younger age, minimum age limit for intraarterial chemotherapy?
Well, 3 months is considered the age because the caliber of the artery is much smaller under that age. And the weight of the child should be about 6.5 kg, 6 to 6.5 kg. That is the limit. But of course, there are reports of even 6 weeks old babies being subjected to intraarterial chemotherapy. So nothing seems to be the limit because we have even 200 micron catheters that are available now. So that is not a problem, I believe.
Thank you, Dr. Santosh. Our next speaker is going to be Dr. Usha Kim, last but the best, who's going to tread a different path and help us understand some more on genetics of retinoblastoma. On to you, Dr. Usha.
Thank you, Dr. Chitra and Dr. Vidya for giving us this opportunity. And thanks to Santosh again for including us in the PG sessions always. So now my topic is going to be a little shift from the normal talks. It's not going to be very interesting, but I'd like to stress on the basics so that people understand. And all the more it has relevance at this point of time because staging is part of the staging is including the genetics. So let me start off. Yeah. So the questions that parents commonly ask the doctors, treating physicians are, will the vision be affected? Is it one eye or both? What is the cause of this disease? And will my next child get retinoblastoma? And this is something that any parent should be given clear answers to. So the only probability that we have to answer all these questions, at least most of them would be the genetic testing, which provides a sense of relief from the uncertainty which they have to undergo. And you also could make some informed decisions about managing the disease. A negative result can eliminate the need for an unnecessary screening. And a positive result can direct a person towards prevention, monitoring, and treatment options. Each of these are very, very relevant and significant. And so genetic testing plays a very important role today. So now let's look at what this genetics is all about. Retinoblastoma is actually caused by the alterations in gene called the RB1 gene that actually protects the cell from becoming a tumor. So two alterations are required for developing retinoblastoma. Let's look at what the heritable does. It affects mostly both the eyes. Sometimes one eye can also be affected, which I'll share with you in a moment. There is high risk of other cancers, and usually the alterations are identified in blood apart from the tumor as well. Now the non-heritable ones affects only one eye usually and almost always. There's no risk of other cancers, and usually the alterations are identified only in the tumor. So for heritable, it's both in the tumor and in the blood, whereas for the non-heritable, it's only in the tumor. And for heritable, it's usually both eyes. One eye could also be affected, whereas in the non-heritable entity, it's often only one eye. And other risk factors, other cancers are not common with the non-heritable. So this is one important aspect and gives a lot of sense of relief for the patient's attenders. Now, the benefits are predicting the risk of retinoblastoma for the siblings, either the brother or the sister in an RB affected family, knowing the chances of passing on retinoblastoma to their offsprings, and understanding the possibility of getting other cancers in later part of their life, eliminating the risk of RB and avoidance of frequent examination under anesthesia in children, because retinoblastomas occur only in children. Now, we do have a wide spectrum of mutations that affect our patient population. This was done at our hospital setting, and we have different types of mutations like the nonsense, the missense, splice, indels, deletions, and duplications. All of these do occur in the RB gene, and about 20 of them were novel, unique to our own population, especially from South India. So you need to know the different types of mutations and also what's specific to that particular area. And we also need to know the timeline for the analysis. Often people think that it takes a very long time, but actually the patients report to us with a retinoblastoma. Once we have the patient for enucleation, it takes about a month for them to come for a postoperative review. By the time the histopathology reports are ready and the genetic testing results are also ready. So it almost takes about 21 days to a month. Now, what were the major outcomes through the genetic testing? We have been able to identify familial retinoblastomas, twin discordance, de novo germline mutations, somatic RB cases, and we've also done prenatal testing in patients with retinoblastoma. Now, let's look at few of the cases. Now, this was a patient who came to us at the age of 4 months, and the patient had bilateral retinoblastoma. The history goes that the mother also had an eye enucleated, but she was not very sure as to why it was enucleated, but we assumed that she would have had a retinoblastoma for which she was enucleated. Subsequently, during the treatment for the first child, the mother got pregnant, and we did a genetic testing in the first baby and the mother, and we found out a specific mutation which was common to both. So we assumed that the next baby is also going to have the tumor, and the child was asked to be brought in as early as possible, and the 12-day-old sibling was brought to the clinic and had bilateral retinoblastoma. Fortunately, it was group B, so we could treat the patient and salvage not only the life of the child, but also the eye and the vision. Now, in this particular scenario, the twin A had squinting and bilateral retinoblastoma, whereas the twin B unfortunately had a retinal scar. We were not sure if it was a regressed RB. So we had to go ahead and do a genetic analysis, and there was no mutation found in the parent's blood. So it was a de novo germline mutation in the blood of the first baby, and there was no mutation in the blood of the second child. So the need for continuous assessment for the twin B was eliminated. Now again, similar to the twins, there was one scenario where one of the triplet was affected. So we had to go ahead and do a genetic analysis to eliminate the need for assessment in the other two children. So the proband's blood was found to have a point mutation. As part of the screening, we did the screening for all the two other siblings, but the mutation was not observed in the two other siblings. Unfortunately, we understood that it was just a de novo germline mutation in the first baby. So the need for continuous assessment was again eliminated through a genetic testing. Now, we often assume that unilateral RBs will not be heritable, but this child presented at 36 months. There was no family history. It was unilateral RB group E, and we identified a germline mutation in the blood. So it is mandatory that we do a genetic screening for all retinoblastoma patients, immaterial of whether it's unilateral or bilateral, immaterial of whether there's a family history or not. Now, this was a proband which presented at 26 months, group E, right eye. Germline mutation was identified and closely monitored. And this patient became a bilateral RB during the treatment period. And on analysis of the parents' blood showed that the father was an unaffected carrier. And then we predicted a higher risk for the next sibling. So again, it's important for all unilateral cases to be undergoing a genetic testing, which could eventually turn to be bilateral incidentally. But then again, it gives us the relevance of analyzing all of these patients with unilateral RB as well. Now, this was a 9-year-old male who came with a white reflex in the left eye and also had a defective vision. He says that it was only for the past 4 months, and then a squinting was present, but the MRI report showed a regressed RB, and this patient had a nonsense mutation. And again, we'll have to keep in mind that this patient has to be closely monitored for the offspring. Now, this was a very bizarre case presenting as Waardenburg syndrome. It was a 5-month-old baby who presented to us, who was referred for a white reflex. We found out that it was a retinoblastoma. The child had colostomy 2 days after birth that is associated with Hirschsprung's disease. So it incidentally turned out to be a Waardenburg syndrome, which was proven through a genetic analysis. Now, this was a 3-year-old child who came with a white reflex of one eye, and there was a retinal detachment as well along with the during the presentation. And the patient had a CT done with, in this particular scenario, it showed an endophytic RB. We did a primary enucleation, and the patient's blood showed it was only in the tumor. It was not present in the blood, which gives us the opportunity to tell the patients that this is not going to be passed on to the offspring. So the proband's blood, the family's blood, that is the parents' blood, and the siblings' blood was normal. So in this context, you can say that the incidence of occurrence of retinoblastoma in the offspring would be just less than 1%. Now, in the adults, patients do come to us after realizing that there is a lot of genetic analysis going on. A patient who was enucleated way back in 88 came to us with no family history of retinoblastoma, but the child was enucleated. The patient was enucleated when in 88, and when the child was 6 months old, and they wanted to know whether there is any chance of the patient passing it on to the offspring because she was going to get married. And since the blood showed negative for mutations, we said there's just less than 1% chance for getting retinoblastoma in her offspring. Now again, there's another patient who came to us asking for any risk of secondary tumors. Again, this child was enucleated when the child was 2 years of age, way back about 20 years ago. And since there was no history of RB in the family and there was no mutation identified in the blood, there's no risk of developing a secondary cancer, and this led the child to live in peace later on. We also did a prenatal genetic testing for some of the patients where the wife, the proband and the mother had a deletion, and the family wanted to know the risk of RB in the growing embryo. Unfortunately, it turned out to be positive on the fetal DNA proved to be positive on a prenatal testing, and the parents had to go in for an abortion. Thank you very much. There are many, many such opportunities, but I just didn't want to elaborate too much on other areas. There is also something going on around epigenetics. So it doesn't stop here, but I think this is all that's sufficient for a postgraduate at the moment. And I think we need to emphasize that it's a new addition to the armamentarium of the staging of retinoblastoma. Thank you very much again.
Thanks a lot, Dr. Usha. That was an amazing talk. I think I found it most interesting. And Dr. Vidya, can you take a question before we conclude?
I just have one question. Like, what about the prenatal diagnosis using amniocentesis? Like, is that what you mentioned in the last case, madam?
Yes, Dr. Vidya. That was what we did in the last case that I shared, was a prenatal diagnosis that we did by doing an amniocentesis. And it was unfortunately positive, so we had to terminate the pregnancy. Because it
and if it turns out to be a germline mutation in the parents, and how early the child has to be brought to the hospital for a checkup?
If there is any positive history in the family, the earlier the better. The best, I would say.
Any other questions? Shall we conclude?
That's all from my.
That was a wonderful session. I am sure some of you are still there. And it's been a real joy for us to be a part of this very informative webinar. And my thanks to the truly expert panel we have. And of course, a superb set of speakers who really gave so much information in those 8 to 10 minutes, which was allotted to them, sadly. But I'll remember you all again and again for our future webinars. My unfailing thanks to the admin team of AIOS under Mr. Kripal has to be unfailingly remembered. And I'm sure you all know how Mr. Sunil, who's our webinar admin, unstintingly helps me by ensuring that the sessions run on time and also keeping you all connected with sending you all the links on time. And my very special thanks to Sai and Manjula from Numerotech, who are literally the backbone for all our ARC activities. Our thanks is really deep felt when I talk about Entoad and how they have sponsored every single webinar of ARC, which helps me come forward with more and more webinars. And of course, my deep felt thanks to my dear little Vidya, who has been a support always for me, not just this webinar, but in every venture of mine. And finally, I think we owe it all to our attendees who keep watching our webinars, and it sort of encourages us to come out with something better and better each time. Thank you, one and all of you. Thanks a lot.
Thank you.
Thank you.
Thank you. Bye-bye.